All right, I think we're going to get started. There will be a couple more folks who trickle in, but we're going to get started.
I want to use the MSA for this session, so don't need anything to start.
Great, thanks.
So, good morning, everyone. Thanks so much for joining us. We're going to have a couple more folks who trickle in, but we're going to get started. So, this is the Emergency Department Operations Workshop. We're here for 4 hours this morning. Thank you so much for joining us. Thanks for taking the time out of your morning and for registering for another event. These are our disclosures. My name is Daniel Shaw. I'm faculty at Beth Israel Deaconess in Boston, and I'm doing some of the coordination for this morning, so I'm going to be starting things off. And then we have a great group of presenters who will be presenting a whole bunch of really awesome topics. It's a lot of material, so we're hoping that this is a crash course that's an introduction to things that we think are high yield, and hopefully it is for you as well. So here are our disclosures. In preparation for our session on negotiation, all of you should have received a handout for either the ED director or ED nocturnist position. If you have not received it, Brian here will hand you a sheet. Take a look at it as we're getting started. Partner up, or at least be at a table that has people. Ideally, it's a one-on-one negotiation. If there is an odd number of people, ultimately that's also okay. All right. So these are our mission and goals that we posted, so you all should have seen these before, but the goal of this morning is to support professional development of leaders in academic emergency departments from an operational perspective, and we want to highlight some of the unique operational considerations of academic EDs because they're different than the community counterparts. And specifically, we're hoping to describe the unique features of academic EDs. We hope that at the end of this, you're able to demonstrate some understanding of approaches to ED management and physician staffing, conduct successful quality assurance and process improvement, and to describe some of the range of careers. So there are a range of folks at different levels of training in the room, also amongst the presenters. So hopefully there's something for everyone here. This is the agenda that we have for today. So we're doing introduction to goals. I'm going to present briefly on unique aspects of academic EDs. We're going to have a session on leadership, change management, and negotiation, staffing models and efficiency. We'll have a break for about 15 minutes. We'll talk about provider and patient experience, quality assurance, process improvement, clinical pathways, career development, and then we'll have a panel discussion at the end. Hopefully it's pretty fast-paced. We have a lot of presenters, and most of these sessions are split between two folks, so hopefully we'll keep you engaged in the material. All right. With that, I'm going to get started and talk about unique aspects of academic emergency departments. As I said, I'm faculty at Beth Israel in Boston. Also, for this, thinking about things a little bit from my perspective of community emergency department leadership, where I also have some administrative roles. I have no conflicts of interest to declare. So my goal for the next 10 minutes is to provide a high-level overview of academic EDs and some framework for what we're going to talk about for the rest of the morning. And specifically, I want to talk about what makes an academic ED an academic ED, some of the stakeholders that we have to manage, operational constraints of working in academic ED environments compared to other environments, how we go about making change, or at least a very brief introduction to that, and then where we might be going as academic ED leaders. So academic EDs are the small minority of centers within the United States. It's about 5%, but it makes up a disproportionate role of both patient encounters and has influence throughout the entire system of emergent care. Tertiary receiving centers, where most of us are working in some capacity, have higher proportions of trauma patients, high resource utilization. They care for the sickest patients, so it's high case mix index, and transfer centers for a lot of their community counterparts. It also provides a lot of safety net care, so it's disproportionate share of government pay. So this has financial impact for the types of patients we care for and how we can care for them there. And there's the training mission and research mission that's also baked into the identity of academic medical centers. Academic medical centers have a tripartite mission that they describe. So it's both patient care, which exists in all of our hospitals, community hospitals and academic hospitals, as well as focusing on education and research. And ideally, these are all informing each other. What this means in practice for people who are trying to lead in academic emergency departments and become operational leaders is that there are a lot of stakeholders to manage. So not only are there all the patient-facing components of this, but there's also education. So there's trainees who have their own perspectives, residents in leadership, medical schools, deans, other folks who get involved. There's the research mission, so people who carry funding and might have outsized weight in decision making. Faculty who have specific research interests and aims. There's protocols and pathways that get implemented in care that we need to address and adjust for. And then the patient care is just, the patients are more complex. They have more needs. They might have fewer resources. There's a whole administration that is tasked with managing that within academic medical centers. And there's a lot more staff who have their own views and positions on things. When we think about trainees as stakeholders that we need to negotiate with and come up with ways of managing and operationalizing, there's questions of quality of care as well as supervision. So trainees can be a great source of motivation for us to provide better care. They can also push faculty to provide the most up-to-date care and stay informed. They also require supervision when they're not familiar with procedures or cases. And there's a rotating group of learners who might include everything from medical students to off-service residents to EM3s who are almost, or 4s who are almost ready to practice independently. And so there is often a push to standardize what we do so that it fits all learners to some degree, to a degree that is different than community counterparts. And also there's a trade-off maybe, or at least a consideration of efficiency versus educational priorities within the setting. So patient presentations from medical students, from residents are not necessarily the most efficient way to proceed with patient care, but they are important educational tools. And so I think we're all here because we believe the training is really important and figuring out how to mitigate that and get through these layers of communication from student to intern to resident to attending to provide the most value to patients and learners is a really important part of our task. The research faculty at academic medical centers have their own perspectives and interests. And so this is generally going to increase length of stay and utilization of lots of resources across the board. There's research assistance, consent processes, interventions. This is all really important, but also factors into how we conduct the operations of emergency departments. And then for this group in particular, and at this conference, we have the opportunity to produce knowledge and to produce research around these topics, which helps to both validate and make it credible, and to improve the projects that we think are important. So this is a valuable tool for making the changes that we want to see in emergency department operations. Patient care, patients are their own group of stakeholders here, and I believe, and I think a lot of folks do, that the operational leadership's goal is to prioritize patient care and efficiency within departments. There's a lot of folks who have their own perspectives and their own operational needs, and there's needs around staffing and learning and research, and the operations team can really make a pitch for doing what's right for patients from a staffing perspective, and this includes things like night shifts and protected conference time, and working this into a schedule that makes sense for providing care. And then we're also held accountable for patient metrics, this is an example of CMS quality scores for the center where I work. A lot of this we have control over as operational leaders, but most of it not so much. So there are things we can measure, like doc to dispo time, 72-hour returns, chart completions. Those are places that we can usually move the needle. Things like 30-day readmissions, door to doc, and boarding time. Sometimes those are less able to be moved from an operational perspective. We practice within a large network, a large system where there's a lot of constraints. And unlike our inpatient colleagues, we cannot stop seeing patients. Sick patients come in, we have to see them, and that's different than a lot of other parts of the hospital where things are scheduled. And you can stop for dedicated educational time, like rounds or conference. We also work within networks where patients are showing up to us, whether or not we have capacity sometimes, so things like trauma, STEMI, strokes, and fitting all these puzzle pieces together is something that we'll talk a bit about. The ED is rarely a profit center in most centers, and so everything that we do is within the context of there's not infinite money or infinite resources to provide the care that we think patients deserve. Academic centers are, generally speaking, have longer lengths of stay, more boarding, and this is compounding throughout the medical center. So consultants, admitting teams, dispositions, the more trainees, the more staff that are involved, the more complex the decisions, the longer everything takes. This has been shown in studies. This is by Resnick et al. Showing the length of stay time and longer for academic centers. As I mentioned, training is very important. We all believe in the training mission. It is not necessarily the most efficient way to move patients through a department. There are ways in which that can be mitigated and deployed, and you can have a lot of providers who with fewer attendings, but it does lead, I think, to longer length of stay. And there are approaches we can take to mitigate some of the inefficiencies inherent in that, and to deploy pendings at the right times, staff the best way that we can, and to have APPs in the right places. We're all practicing within a framework of lots of crowding. It seems to keep getting worse. And academic EDs have increased throughputs, slower throughput, and delayed outputs. So this model that's been deployed of inputs, throughputs, and outputs for crowding, academic centers are being pushed in every one of these dimensions. So more complex patients, more of them coming in, inability to decline transfers, having throughput delays as far as efficiency, and then difficulty placing safety net patients and complex patients when it's time to ultimately disposition them from the hospital. We're tasked with serving as receiving centers for tertiary patients. This is some work that I did recently looking at the consultation rates for patients who are transferred from our community hospitals to an academic center. And disproportionately, the largest consult service is neurosurgery amongst these for an odds ratio. But surgical subspecialties, we're seeing a large number of those as well. And so partnering with our specialists to keep patients in their local communities wherever possible and expedite the care of patients who do need to be transferred and making sure that we have those service lines in place is really important in a way in which our roles as operational leaders intersect with the rest of the hospital. There's also working with the transfer center to make sure we're accepting patients that we have capacity to care for and declining those patients that we don't have capacity to take care for, and potentially getting patients out of medical centers, AMCs, to community hospitals where it makes sense to do so and getting them to the most appropriate level of service. When we think about AMCs, these are large practices generally. They're less nimble than small practices. It's potentially hard to make staffing changes. And they're often integrated practices where there's smaller hospitals that are part of them. And so networks often impose top-down priorities that then as operational leaders we are tasked with deploying and putting into place. The compensation structures are variable. They might be pay per hour or pay per patient or RVU based. These are going to incentivize different types of behaviors from physicians. People who work at academic medical centers are different than those who work in the community purely. And so there's a question of how do we get the right people to the right places doing the work that they want to be doing. And then I don't know about everyone in the room, but certainly when I work in an academic medical center, I have a lot of bosses. There's a vice chair of operations, quality, there's chairs, there's vice chairs, there's CMOs. This is a different management structure than exists in most community hospitals, and figuring out where to manage in that chain is an important part of the work that we do. So that's a very high-level summary of things that I think are different about academic centers. As in most systems, the frontline workers know the problems with their jobs, residents know the problems with their jobs, techs know the problems with their jobs, but the priorities are not always the same, and what they're trying to achieve is not always the same. And so one of our jobs is to figure out how to approach that. I think valuable tools within this are to show the data. Physicians in particular respond better when they see the data, see the research, and understand what they're being asked to do. If we make our work research, it validates the work that we do in operations. If we publish on it, if we show how to make things better and what the problems are, that lends it a lot of credibility. And then in these centers where we have a lot of bosses and a lot of supervisors, figuring out how to manage both up and down and everywhere in between is an important part of the work that we do. So this is a comic from XKCD that I like. So it's a lot of problems there. We're going to discuss a lot of problems. My hope is that we can make some sense of them and provide some framework for them over the course of the morning. And hopefully we can talk a little bit about where we're going as well. We're all dealing with crowding. In my own network at Beth Israel in Eastern Massachusetts, we have a network of community hospitals, academic centers, urgent cares. And I think increasingly we're going to be looking as operational leaders within academic centers at this whole spectrum of care, not just how does the academic center work, but how are we getting patients to the right place at the right time, keeping them out of academic medical centers when they don't need to be there, getting them there when they do need to be there, and doing so efficiently. So in conclusion, this is a high-level overview. We're going to talk about a lot more of these topics. Academic EDs do have unique operational needs and constraints. They have a lot of stakeholders, and we're going to see, I think, increasingly integrated networks where we're going to be thinking about both our community hospitals and academic centers as a combined unit. So happy to take any questions at this point.
What do you think some of the barriers are to making those large academic groups nimble? You said, I mean, you would think like with a larger group you'd be able to like, you know, have a shift come up to every, you know, like that you might even be able to absorb some of those like, and so what barriers, if you could just go in a little detail about like.
Sure. So I think the question, and every group does this differently, is how do you staff some of these sites? So with my group, we have academic faculty that also work. Everybody works some degree of community time. And so that creates a lot of flexibility as far as can you send people who are at the academic medical center and add a shift and send them to some other site. But credentialing is not necessarily uniform across the board, so not everybody's credentialed at every site. For academicians, if there's a research or operational role, they're pretty reticent to pick up even an additional shift a month, I think. And other people's experience may vary, so you can do that a couple months, but at the point at which you're adding additional shifts several times a month, people start, that does not necessarily align with the goal of academic centers. I'm curious other people's experiences, but if a community doc is usually willing to work an extra shift a month for a while and they're there to work, and it's not necessarily a huge hardship. You add an extra shift for somebody who has jobs as a medical director or vice chair of something, or has big research interests with a grant. That's time that is taking them away from their other work. And so, you have a deep bench that certainly is going to help allow you to make changes where you need to. But ultimately, I think this is the experience in my practice and others that I've heard. People are practicing at specific sites. They're not necessarily practicing at the network as a whole. So I think that's part of the reality of how we actually work our shifts.
Thanks.
Any other questions? All right, awesome. Thanks, everyone.
Morning, everyone. I was gonna detach myself from the podium, if that's okay, since it's a smaller group. I'm Brian Yoon. I'm the first physician, the vice chair of clinical affairs at the Department of Emergency Medicine at Boston Medical Center.
I'm Tracy Vermeulen, medical director at Mount Sinai Hospital and faculty here.
One disclosure.
Yes, my one disclosure, ran the lower LED pathway.
So the agenda for this morning on leadership negotiation and change management is we're going to do a case study, we're going to debrief, we're going to do another case study, and we're going to debrief. And we're going to layer on some principles of negotiation change management that is going to be really a crash course on this, because you take multi-week courses on negotiation. So I think first and foremost, like when we talk about why negotiation, why focus so much on the negotiation, like at the fundamental level, we as physicians, as people, you have kids, you have partners, you're negotiating pretty much like everything, right? And all these concepts that you're going to learn here today can be applied to those scenarios, but also most importantly, right? And really, what you want in a boss, or eventually when you're the boss, is that person or yourself to have these key negotiating principles, because what makes a great boss, what makes a great leader, it's those who can be effective negotiators and negotiate up and also negotiate down, right? Getting resources for the department, but also when you are interacting with your colleague or someone that reports to you, having that conversation and then coming out of it better, both individuals in a better state of mind. And so with this case study, we're going to go just dive right in, right? This is going to be an interactive session. Everyone here should have gotten either the ED nocturnus or the ED director, and you should have a partner. You can spread out. There's a table over here. There's two tables over there. It's a one-on-one negotiation. This is not like team up on someone. Guys, it's a one-on-one negotiation. Do not share, like, it's confidential. Like, you can, of course, like, convey any information you think is necessary, but don't like, give the other person the shoot, right? And then afterwards, one person from each group is going to fill out a poll to figure out what was the agreement that we came upon. If you don't have a partner, it's simply you don't have a partner, you can observe a session going. So again, everyone should have a partner, correct? Besides Cynthia? Good. Cynthia's going to observe. Everyone else, partner up, and you'll have 10 minutes to negotiate. I think there was one question actually if there's questions, like raise your hand.
Want me to negotiate with Cynthia?
Okay, so 10 minutes.
Use nocturnes?
The clock will start now.
Yeah, I haven't even.
You guys can do which one you want.
Thank you.
We've got two, so.
Which one?
This was the free coffee I got, and this is the coffee I went to go get, so.
Do you need coffee?
I'm good, thank you. When is isn't there a committee meeting tomorrow or Wednesday or Thursday
Thursday morning.
during all the ops abstracts?
No, the committee meeting's 8 a.m.
That's when all the ops abstracts.
Oh, really?
Yeah.
Yeah, they never arranged it.
Yeah, I have to present mine at 8:20, so I can't. It's gonna be here.
A bit of a hissy fit last year when they scheduled the ops meeting Friday morning.
Yeah.
Right, exactly.
Yeah, if it's one of the ops Thursday here. Yeah, like the e-poster session Thursday morning, clinical operations. It's just the three of us.
Okay.
Two of them this is Gordon.
Okay.
This is one of our, and this is me. Oh no, there's more at the beginning. Yeah, clinical operations 2. You scheduled it right during, not you, but yesterday I scheduled it right during. Ugh.
I went to Staples and I was like waiting for construction paper, and I was like, oh.
Did you find someone to take over for you next year? You have one more year at the helm?
One more.
Nice.
Officially, announced we have a couple of officer positions.
Yeah.
Certainly it takes up excellent board and side. I can be like, I think these people are fine, but I don't know that they're going to appoint somebody.
Nice. Should I practice negotiating?
In life, yes, ever.
I'm a bad negotiator.
No comment.
I feel like that means that's echoing.
She's not here, right?
No.
You're not paid by the
Yeah.
She was not here.
I know there's only I understand how after your first episode, just like stop eating these things. Okay, don't let me into somebody. Once upon a time, we were in Vegas. There was a buffet with someone with his friends. And the next morning, he gave his talk in sandals. It was all red. Yeah, crumbly toe pie coming out of his ear.
I need these sprouts.
we're at the halfway mark. You have 5 more minutes. 5 more minutes.
Working on this long-term getting out the door and like that. Data cleaning happens, so I just keep sit down. It's like I need to read something else, but I've got so follow up to the WC stuff. Trying to see language and studying like resourcing predicted something
Just so we can regulate the next out of
yeah.
submit to like the same time. So then right and
Yeah.
but like the way I was thinking about it, it just like because we have so many data that you should be able to like different data.
I like these cases.
Like the body. Like yeah. They're in play. Right, and I don't know statistically how to
Yeah.
I mean, I think that one. And the other thing
They didn't let Cynthia in because she didn't have a ticket. Cynthia got kicked out by the person who looked. Just make sure it's off. So I had to go. This.
That was very nice of you.
What brewery are you guys going to?
Victory?
I don't know.
Oh yeah, if you could run, if there's going to run those like, and I can
It's a half mile away. Half mile away.
No, you want to come?
I think so. I was gonna. Yeah, I gotta just take some meetings when I may.
there should be enough
Yeah.
like still maybe it's one thing to make sure
Gonna meet.
okay, I think that
How much money do you want for this job?
What?
How much money do you want for the job?
$500,000.
Oh, can't do it.
Okay. It's interesting because I feel like the P&L.
2 minutes left. 2 minutes. 2 minutes.
This is something that like I honestly personally we should practice this. We should do this at like fellowship. Not like this one specifically, but like because we don't in our system we're like very P&L. Like you can negotiate a little bit here and there, but we are like you make what you make, and like in theory it's pure. And there's like theoretically you could be like, hey, I want more. I want $60,000 instead of $30,000 stipend. Like you can argue that, but like it's in our like high level ossified autocracy. There's not really arguments for that. Like we're not going to rich and like arguing for more ops stipend money right now. So I feel like this would be something that's useful because we don't do it in the P&L system. We should incorporate like we should have like a day of it on this.
I mean, it's a big problem for hiring, though.
Yeah, because you guys do it more for hearing. Like
Yeah.
right that's like
And when,
so I feel like
when you're getting paid $140 a patient as opposed to $200 a patient at Eden, that's a different.
yeah. But I feel because it's both sides. Like if I had to leave and negotiate, I would need to be like to practice before because I haven't had to negotiate my own salary
Yeah.
in a while. I've just been like thinking that it's been adequate, and I'm also pretty.
Yeah, that's a good point.
So
So I'm supposed to set the anchor high.
what
You're supposed to set the anchor high, but not unreasonably high.
exactly? Yeah.
So in this case, would be like 350, 300. I mean 200.
Okay, if it's time to get down to
Yeah. Not
a salary, you've got
30 seconds. If you've come to an agreement, please, one of you use this QR code to put in what base salary you agreed upon. 30 seconds to finish your negotiation and fill out, just one of you, one person in each group, fill out what base salary you agreed upon. Sorry, was it too far? I don't know how big the room's gonna be.
Yeah. Zoom in. So you still have to interview. You're still looking for jobs. You're still figuring out jobs while you're just working.
Yes.
If you did not come to an agreement, that is an option. If this did not come to an agreement.
Is that next to Peter, or is it?
Yeah.
So like parallel to Peter?
Yeah.
Oh, wow.
Okay, we should stop negotiations for time. Take this QR code and just one person each group.
What salary?
What
do they
is
offer?
on what salary?
For how many clinical? 8 to 9 plus vice chair, like academics.
This QR code is going away. Let's see.
What folks? Okay. So people settled around 220 to 240, 240 to 260. Was there anyone who didn't have a deal? Yeah. Well, let's switch gears. Okay, so basically what you all just did. Oh, yes, fine.
Is that dollar value just the salary alone, or like if we negotiate that on the price?
That was just salary looking. But you're kind of getting into it. Yeah, eventually, but. So,
I took a signing class.
yes, that's right. Well, ask in a second. So this is an example of distributive negotiation, right? Now, this is like classic negotiation where it's zero-sum game, right? It's winner-loser, fixed pie. And what is characteristic of this distributive negotiation is it is a one-issue that's on the table. You're basically negotiating on movie management. Many of you might have expanded, and we'll talk about that in another case study, but still at the end of the day, in essence, this is what's the number going to be. Just notice though that there's an opportunity to go beyond that, right? There is certainly tactics where many of you settled in this one area, but there is a possibility, even with fixed pie negotiations, to go beyond that. So we're going to go into each of these three things a little bit more into detail, but when you identify that you're going into a fixed pie negotiation, in general, there's three things you need to do. First is determine your background. We'll talk about what that is. And more importantly, is to try and figure out what the other person's background is. Second is, in these negotiations, figure out who is going to set the anchor. And if an anchor is set against you, to diffuse it. And then the third is, as you're communicating, watching your concessions, understanding the rhythm of your concessions, and the amount of
Yeah, and you'll probably notice this naturally as well as when you were doing this case study. But one thing, and this is all just based on like previous literature, is, anytime you have any type of negotiation strategy, you have to think about the individuals involved and how you adapt the strategies and serve you. So specifically here and throughout the rest of our presentation, much as you can and really referencing objective benchmarks. So the AAMC has the faculty salary annually in terms of what to expect based on your discipline, region. Those are hard numbers that you can always reference. Same with, I think it was referenced earlier, the Benchmarking Alliance also has numbers when it comes to like on average communication per hour should be effectively and what that expectation would look like. So again, the more explicit and objective data you can use and reference in your anchor can really support you to really minimize the impact of any bias in this negotiation. And like Ryan was mentioning, if there is an anchor that's initially thrown out at you, it seems like a low ball, you can use it. And then same with the concessions, right? So it's tricky again because again, research shows that women and people of color are more likely to experience backlash. We'll get into that a little bit more on the next slide as well, but making fewer concessions. So the more you can lean into data-driven notifications, that allows you to do that in a way where you're not penalized for that. And so the backlash effect, there are different ways that that comes into play, whether you're really aggressive or less likable. We all know this when you're like trying to interview with someone or negotiate. That is something you're thinking about at some level, right? Like whether you're interviewing an applicant, you're like, well, would I want this person on my team? And so just based off unfortunate reality of how certain people that are forced to navigate society and how they're perceived, you asking questions that are totally appropriate and make you seem quote unquote less likable. So that's what I mean by the backlash effect. That's been studied in literature. And then, with lower initial offers, right? So back with women, for instance, do receive lower starting salary offers when you are engaging in negotiation, despite low qualifications. But when you start off, with a lower rate initially, there's been research that shows that if you look over time in terms of their promotion tenure, that gap does remain. So it's really difficult to remove yourself from that trend and being able to again rely on objective data can help. The other thing also is salary transparency, which is not the case in a lot of work environments. The more you are able to engage in a conversation with your colleagues, and so one strategy, for example, is just asking your colleagues like, hey, I mean, this like when it be less, and just I'm not gonna offer you my salary, but you're trying to learn more about like what happens in our department. And some people you might be surprised, we'll share that information with you. Depending on who you ask, the pitfall is don't ask one person, it's actually skew your percentage. You want to ask people to kind of get a better sense. And then skepticism toward value claims. This has also been shown that women in populations of color have to provide significantly more evidence to justify their work. Again, even with equal qualifications that are written on paper, things like greater visibility, making sure that you are engaged in more of those informal interactions with people you identify as potential stakeholders or partners that you're negotiating with really come a long way. It is more effort, right? It is more labor, but it does pay off dividends. And the same with research looking into what your allyship. But harder to do with distributed negotiation, but we'll talk about that when we talk about it. And then, this just really summarizes it in terms of how what are evidence-based strategies to do this. So again, using external data anchors, it also just allows you to take the emotion out of it. That can really sometimes muddy the water when you're having these types of conversations. So the more you can say calm, objective, data-driven, it really just helps you during these talks. And then, this in particular, the framing it as with a shared institutional goal, for better or worse, women, for instance, are seen as more communal in terms of leadership and their other traits. And so if you leverage that in some way, this is better for the department. And this is, how these are making this role really serve your needs. But the more you also understand and make yourself in the minds of who you're negotiating with, it really helps you frame that ask in a way that's effective. And then finally, your working confidence setting. So talking about this later on as well, you're talking about DOPAs, but historical questions aren't always favorable for certain people in our society. So how do you really take that from the
So, with that context in mind, acknowledging that there are different forces at play here, first step is to identify, okay, I think this is going to be a win-lose situation. If you've identified that, then the most important part you can do is your whole plan. It's like you lose basically if you're, what's the term? If you're unprepared, you're preparing to lose, right? And with any of these negotiations, it's about collecting some of that market data. It's the understanding what are other people getting, right? All those concepts and starting to perform that stakeholder analysis. So who's that other person that you're going to be talking to? Are there other people? This was a one-to-one negotiation, but in a multi-party negotiation, everyone is going to have their own, their biases, they're going to have their own interests at play. And then on your side, the BATNA, it's the best alternative to negotiating agreement. This is basically like, what would you do if you can't come to an agreement? And depending on where your BATNA is, that can play into how strong your negotiation is, right? In this case, if you had some other person offering you $1 million, your BATNA is pretty darn strong. But if the other person is offering you, 100K, your BATNA is potentially pretty weak, right? So understanding what would you do, and more importantly, trying to get a sense of what would the other person do. Because if you understand what the other person will do, that's when you start understanding what's the sum of the possible agreement. In this negotiation, I set up the case that there is a silver. There is a possible agreement, which is why you all kind of naturally landed in that 240 period of time. But, to acknowledge, not every negotiation ends in an agreement. Because there just might not be a silver.
Sure, I mean, and we touched upon this as well, but it's easier said than done, right, can I say? But thinking about, again, who are you speaking with and what are, in terms of them more specifically, have they behaved in the past or have their actions exhibit that may hold certain biases? So how do you avoid activating those stereotypes? And the same with the ZOPA, again, for president isn't always favorable for everyone. So really the more objective you can be, I know I've said that like 5 times already, but really being data driven in terms of how you're presenting yourself and what you're asked allows you sometimes to maybe even shift that ZOPA if historical evidence not in your paper.
So if we model this, what would it look like, right? So on the top, we have a buyer, and then the seller, basically, right? So buyer, seller, concept. But if we put on what we just negotiated, you'll see that the director versus the nocturnist, you'll see that the director actually had this 200 to 280,000, and the nocturnist had this 210 to 290,000. The director kind of wanted to pay you 200,000. You kind of wanted 290,000, right? And then the other potential opportunities there were that you as a nocturnist had this $210,000 offer, and then the director was willing to go up to 280,000, right? So that's the ZOPA that we were talking about. Then you settle right in the middle. Anchoring. So did any of you want to ask? Did any of you put out a number that was really far off left or far off right?
I mean, so I was the nocturnist. My initial counter offer, what did I say, 280? I went pretty high with my initial.
Did anyone offer? I didn't reach it. What did you say? So you did 210, 310, and you did 280.
280.
What did you settle on?
250 and sign on.
250 and a 20K.
240 like at 3,000 and 752.
Did anyone go higher than the 280-ish, 270? When the ED directors, when they put out that offer, what did you do? Did you just nod and smile? Did you scoff? Did you freak out?
collection negotiated, and also not really that's that money.
So you negotiated?
Yeah, I think when anything you throw a first number out, the expectation is gonna be negotiation, right? Nobody takes the worst number. So I think you take our first number and say, included, we're not gonna settle on that number, so know that I'm gonna go higher and the other person is gonna go lower. And I think, yeah, that's a starting point, so if that's the expectation, I don't think, nobody ever takes. I think somebody were to scoff at that, I'd be insulted and say, have a nice day, right? Because the expectation is negotiation.
Yeah. Yeah. So it's really fascinating, right? Is that like you're entering a negotiation, your mind's saying they not realize or they realize that they're in a negotiation. But anchoring by itself is, as everyone probably understands to a degree, is it's a bias, right? The number that's I gave you all this data, but at the end of the day, your first number, even if it's not tied to any scientific reasoning, will put the other person on their heels, right? And like we see this all the time, right? With vehicle MSRPs, right? That's an anchoring number. Donation request amounts. So like, you get an alumni letter saying, please donate, and they'll say $150. But right under it, they'll say $100, $50, and that $150 is an anchor. It's not. There's no like science that says $150 is what's going to stay in school or in your university. It's just like you look at 150, and personally, you've been like, oh my god, that's a little too much. Play all over $100. But like that's an anchor, right? It could start at $20, and if you start at $20, you're probably more likely to get like the $40, right? And so the anchor by itself, or eBay's buying now. So I don't know if you've been on eBay lately, and eBay's thing is all about like you bid, the price goes up. But you probably noticed right next to it, you'll say buy now for like $500. And that's not like most people don't select that. That's just an anchor. Like by putting buy now, suddenly you put value on what you're gonna buy. And so you think anything less than $500 is a deal. But again, that $500 is not perhaps associated with the value of what you're buying. It's a psychological bias that is put into effect. And so, at the end of the day, it's like, okay, how am I going to decide if I'm going to put in the first offer or wait for the other person to give the offer? It's really based on like who potentially has more information, right? Which is going back to doing your homework, doing the research, understanding the market. And so if you know the SOPA, make the first offer, but as Terry mentioned it, to wrap it in some reasonable explanation. Why I have this stuff. If you don't know the SOPA, then either let the other person throw the anchor, the opening offer, or provide a soft anchor. Like, for example, for a salary, you might say, I'm interested in a salary that's like 210 to 215, but looking at what other responsibilities, right? So it's like I'm being reasonable, but I also have a number back in my head. Now, I think this is quite important. We're as humans, we're social, and we respond to social cues. And so if someone throws a ridiculous anchor, and if you don't respond, that person's going to be like, well, I think we didn't reason. So if it's totally unreasonable, you need to actually say, like, forget it. Because otherwise, you're like, oh, you're like in the negotiation, you're thinking, I want to win this, but that anchor is going to psychologically go against you. So if someone throws an anchor that is unreasonable, you need to respond forcefully and try to use that anchor. And then really quickly, as to your point there, it's like once you've thrown a number, it's all about then they're probably going to set somewhere. But how you concede your offer is an important, right? The bigger you concede, the earlier the signal that you're giving is more, right? But as you get smaller, that's saying you're getting closer, right? And oftentimes the midpoint is that semi-reasonable offer that you contemplate. So if you're looking at, I want 250, don't start at 250, or else you're never going to get that 250. Again, to your point about throwing the number is starting the negotiation. And then influence, as we mentioned, in the interest of time, we'll just blow by this, but making relative comparisons, framing the conversation, and using social proof, herd mentality. Again, all concepts that Thierry just mentioned. Case study 2. Excuse me. Okay, so this is a group case study. We're going to do this together. So you're the medical director of an ED that sees about 70,000 patient encounters a year. Last year, you developed a split flow model, so it just means that you're seeing some patients vertically who are lower acuity. And currently, every walk-in patient, regardless of acuity, is getting fully triaged. So it doesn't matter if you come with like, I need a doctor's note, I have a paper cut, you get fully triaged. And what you've seen over time is that while your docs dispel, right, this is the time that the doc spends with the patient, and the dispel depart, meaning they get registered, they leave, that's all been steady, but like the door to doc, so that's I get registered to eventually being seen by the doctor, is getting worse over time. And you say, okay, like, if you look at the main ED and the vertical ED area, you'll see that, like, you actually get seen quicker in the main ED than the vertical area. And, like, before you even seen by the vertical area, you're like, oh, wow. So, like, that's, like, the whole point of the vertical area is to see patients quickly, efficiently. And so, being as a medical director, you're like, okay, we need to focus on how to get patients seen sooner in the vertical area. So, you're going to start the negotiation with your ED nurse director on how to improve that door-to-doc time. Your ED nurse director would just like to add an triage nurse. But you're worried that it's going to pull an RN away from the bedside because we budget reading, right? So that's the ED nurse director's proposal. So take 5 minutes with your neighbor, talk about how you approach this negotiation and what solutions can you come up with. Take 5 minutes, talk to your partner. So we're behind by 10 minutes.
I get to talk less. I'm gonna steal one of his waters. This is how I get by. Like, I always lunch. I'm like, guys, I had an hour, but I really don't want you talking 30 minutes, and I burn it again. No, it always goes fine. Bye, 10 minutes. I mean, yeah. So I literally it was really good. So all I did was go and do this stuff. So that's site here. I looked at stuff and then like, you know, add all of these references that I do always
1 minute, 1 minute.
See what the new chair is. But I'm not going to be a problem. I've had 4 firsts in like taking place. Hopefully a senior coming soon. Yeah. 2 years as an assistant. But I'm good. This is where I want to be. Perfect. Yours.
Okay, let's wind down. Okay, let's come back to this part. So, as you're finishing up the conversation, this is just an example of now what we call integrated. What differentiates this from a distributed negotiation is that potentially multiple issues could be negotiated. And then that actually opens up different things, because now you could negotiate on people's interests. It's not just one issue, a number, a salary. This is an opportunity now to figure out what's the other person and what's my value system. And from there, you can actually negotiate on those specific topics. So, positions are what's in front of you, but understanding what their interest is the more challenging component of this negotiation. And so, the position that a person comes towards is that there's a demand. But the interests are the reasons behind it, right? So like, even if we take a look at the salary negotiation, that salary that you offered or the salary that you wanted, there's a reason behind that number. And this type of negotiation, you're trying to understand those reasons, because once you start understanding those reasons, you can have a conversation to uncover that and perhaps come to different trade-offs, which some people started doing in the base population.
And we talked about this a little bit earlier as well in terms of like different ways to establish your value and engaging more so in distributed negotiation, but it really applies here as well, right? And more so when you're thinking about how do you really meet with your own interests. And for us as academic positions, one of the easiest things is being there and really thinking about how are we impacting quality of care that we're providing and what are the different things that we need to establish to do that. And then team success. And so really being curiosity driven and asking the different team members and what their interests are. You learn so much in that process. And I think that's really the first important process before you even start delving into your own interests. Because then they're more, depending on who you're talking to, there is also the medical hierarchy, right? If you're engaged with interdisciplinary stakeholders, they may not immediately open up and talk to you about their interests unless you intentionally give them the space to do that and learn a lot in that process of negotiating.
So, taking a blind and full doc, right? The issue is reduced store to doc time. You as the medical director want that. The nurse director wants to add another triage. That's the position. What's the interest? Well, it turns out the ED nurse director is getting complaints from the nurses saying the triage nurses feel overwhelmed. And you, as the ED director, would want to reduce ED discharge on the stay because, as Dan mentioned, CMS stars might be an interest that your hospital is taking, and reducing ED discharge on the stay is why you're so focused on these metrics, right? So an option that was generated, I'm just going to ask for 2 examples. What were some options that were generated to meet these different interests? Solutions?
We talked about adding a provider in triage, and we also talked about
teaming up with the ED nurse to the ED leadership, going to the C-suite and asking for an FTE nurse that you don't have to divert one from the main ED to triage.
Wonderful. So provider triage, maybe go find a different negotiating party, join forces. One more option.
So we were trying to interpret the little bit of data you gave us, and our feeling was there is probably a period of time where another triage nurse is needed, where that time to triage was like 50-ish minutes. Looked like we're like, they may have a point, but what we don't want to do is just burn that resource only in triage. So is there an opportunity for that nurse to have multiple roles? That when we set some sort of a trigger that when Georgia triage is above a certain point, that they flex forward, and when it is not, we sort of admitted that not knowing the rest of the model, it was hard for us to be like, where in this model should they be inserted? But somewhere to deal with actual care or decreasing length of stay and sort of.
Awesome. Okay, so what was the negotiation that I came up with? This was the negotiation I came up with. So what we decided was to implement a pivot nurse. So you convert one of the main waiting room triagers to a pivot nurse. We're budget neutral. And this pivot nurse could then actually decide who are those with lower acuity complaints that they get just by age and the primary complaint. And then they could move that patient right to the vertical care. And the nurses, the other main triage nurses will get less overwhelmed because about 30% of those patients don't need to get fully triaged. They're going to be seen by a doc and nurse team and then another area. And so this is basically help the ED nurse director reduce the number of complaints that the ED nurse director is getting from her or his or her nurses, and then on our side, reduce the discharge length of stay. And this was the results of the pilot. So our door to vertical care went from 44 minutes down to 6 minutes. Our door to provider went from 94 to 47 minutes. Our door to main pod went from 19 to 10, showing that then the main waiting room triagers were able to focus more on those complicated patients versus having to do a full triage on a person who wants. I'm being facetious, but that this is where having multi-area issue negotiation comes. So, really quickly, at the end of the day, the best practice for integrated negotiations, as you can imagine, it's all about relationships. So building trust, ideally before negotiations happen. If you're a new medical director, the first 36 days is spent on meeting one-on-one with potential stakeholders. This is also not a this is not like a spying or type of knowledge. The idea is to share information, but you're not just putting everything on the table. It's about reciprocity, and you're building towards more information sharing. And the key point, as Terry mentioned, is asking the open-ended questions. Start off with what if, what would it take, why not, and really try to dig at what is the core issues here and what are the interests. And insist on reciprocity. If you're giving information, they should give information. It's a similar setup that you all did with your fixed line negotiation. You offer a number, they offer a number. But you're building towards this joint problem solving as one group was moving towards. And then lastly, I'll just point out here is when you have a negotiation, you can propose multiple equivalent packages. Meaning I'm willing to give on this, but I need this. And then you take a variation of that. Because at the end of the day, you might be agnostic to any of those options, but by giving a lot of choices, the other person now has an opportunity to understand what are my values, what are my interests, and they might come and choose one of those offers or come back with an opportunity. So at the end of the day, you're trading on these priorities, this risk tolerance, the capabilities, the forecast, and the time frame. So the person who talked about getting a bonus, that is an example of a time preference. I want the money now. But later on, with a medical director, that is not a reoccurring expense that's going to go up year from year to year, right? And that's where this interest-based negotiation comes into play, because each individual in a party has different tolerances to each of these things. And so you're trading off them. One of the most common is time. Sometimes for you, time is more valuable now, and so you want things that now, sooner, more than someone else. But someone who might be looking at the time pass might say, I'm willing to pay this now, but my cost will be lower in the future. So just keep that in mind. In summary, for this, like, spend a lot of time understanding your background and your counterparty's background. Understand that it's a one-issue negotiation. If it is a one-issue negotiation, anchor effectively, monitor your concessions, use influence. Try to bring a one-issue negotiation into a multi-issue negotiation, if at all possible. And if you're successful in doing that, invest the time to ask questions, open-ended questions. You should spend more time asking them questions than they're asking you questions. Because your idea is knowledge is power in this case. You want to understand the interests. And then create value by trading on those differences that I just mentioned related to time, as an example, or risk, right? Some people want like the $1 now rather than the 50% chance of 10 times, even though they might come into a similar value. So with that, I'm going to pass it back to Dr. Stenson and Dr. Shaw. Spatula.
All right. How are we doing on time, Dan? We're good?
We should move quickly.
Move quickly. Okay. Sounds good, everybody. This is our last talk before the break. So Dan and I are going to go over kind of staffing models, concepts of efficiency, and we'll kind of walk through some of those and how it pertains to academic emergency departments. I'm Brian Stenson. I'm the Associate Ops Director up in Boston with Dan at Beth Israel Deaconess at both the medical center and one of our community sites. So we kind of work with both of these, but this is kind of focusing a little bit on the academic portion. We have no conflicts to declare. The agenda for this time, just to moving quickly, we're going to do a very quick talk, description of what queuing theory is, because I think it's really important to emergency department as you're figuring out staffing and workflow through your department. Talk about very basic concepts, how you define productivity and how work actually gets done with whoever the people are working in your department, various models, alternative workflows, and then ways to kind of set expectations and promote efficiency. So queuing theory. Really, queuing theory is the definition is the mathematical study of waiting in lines. So this is really important to ED operations because our ED is just a large collection of lines. It is triage, it is the vertical care space, it is your all of your providers seeing patients, it is the CT scanner, the lab, and all of these things. And as best you can understand how this works, it can be helpful to predict what resources you have and where you need to deploy certain things, depending on where the queues build up. And the ED is very unique in medicine in general in that we don't control our input, versus like an outpatient ophthalmology clinic where they have 5-minute, whatever, how long the visits take in ophthalmology, but a few-minute visit, they schedule them, they know exactly how many people are going to show up that day. We don't. We can kind of study it based on historical data, but we don't always know what our inputs are going to be. So a quick queuing example that I've learned from these talks over the time. So let's say we have one triage nurse. This is jumping a little bit off your example, much simpler. One triage nurse, they process a patient on an average of 6 minutes. And this is kind of the only, everyone goes through triage. We don't have a provider in triage. What's the maximum number of patients they can see in an hour? 10, great. This is not a trick. And with this, what assumptions are made? What?
Perfect efficiency.
Yeah, so perfect efficiency. We're talking.
People coming in every 6 minutes on the dot.
Yeah, so a 100% efficient system with no waste would look like this. A triage takes 6 minutes exactly every time, and a patient arrives every 6 minutes, in series, so that there's never any waiting time. But this is not the case. As variability is inserted into the system, we get a mixture of things, and we end up getting we're balancing these two ends with every queue that we're working on. Every time that there is a longer time delay, there is capacity that's being wasted. That's a triage nurse sitting there, potentially not triaging somebody when they potentially could have otherwise. Or if multiple patients show up in a row, then you're having people that are waiting, and that builds up the wait time. So it's really important to look at this and understand the variability. If all patients come in every 6 minutes, you'll have 0 wait time. If 10 patients show up right at 9 a.m. and the triage nurse works through them, that's a cumulative wait time of like over 4 hours. So it really depends, and there's the reality is somewhere in the middle there. So we're balancing wait times with our unused capacity. Variability is key, so not just understanding that averages, but also the numbers around it, your standard deviations, your interquartile ranges, because as the variability of these systems increases, your expected wait times will increase. little bit more math here that we'll just breeze through, but Little's law is kind of one of the big concept in queuing theory, looking at the average size of the queue, how many people can you expect to be in the waiting room at a given time, which is your arrival rate by the average length of stay in that queue. And so like a business standpoint would be if you have 20 customers arriving to your donut shop every hour and they spend an average of 15 minutes there, then you'll have an average of 5 people in your store at all times. So you can use that to understand kind of how long you would expect the queue to be. Utilization is the other thing I wanted to talk about very quickly, but this is functionally how the definition of how long your server is active versus idle time. And you're looking at the arrival rate versus the server rate and how often you can, and so to look at how efficiently you can move people through the system. And as you approach 100% utilization, your waiting room times increase exponentially. So while we would love people to be operating at maximal efficiency, as you do that, if someone is running at 90, 95, 100% efficient utilization, your waiting room times are going to balloon up. And the inflection point is usually somewhere around 80%. And there's some math formulas that kind of recreate this curve of the idle time divided by the utilization time over the idle time times the average amount of wait, and it kind of disproportionately increases. One thing I want to talk about, which isn't in a lot of the queuing theory data out there, is when you have a utilization over 1, which we often do see for temporary periods of time. If you insert those numbers into any queuing theory, it will break all the numbers. If you have 10 people arriving, but you can only process 5 an hour, then we'll have infinite waiting times. And we see this in our department in the evenings for CAT scans. We're ordering 6 CAT scans an hour. We can process 4 CAT scans an hour, and all of a sudden people are waiting infinite amount of times until your utilization, your order rates decrease, and people can catch up. So this is a dynamic process that changes throughout the day in the emergency department. So that's a good backdrop that I just wanted to mention. I'm going to talk very briefly about staffing concepts because all departments need to know the 2 aspects of this, which is your patient demand and then your kind of provider capacity or clinician capacity and who is seeing patients. So from a demand standpoint, you're going to look at your total volume, and all operational leaders should have good access to this data and really look at it in real time. What patients are arriving? So ESIs, admission rates, discharge rates, ICU rates. When do they arrive? What hour of day? What's the variability on that hour of day? Day of week, seasonal changes for patients for hospitals that are in that have big seasonal variability. So it's really important to understand that and know who are the patients and when are they coming in. And on top of that, we care a lot about what percentile do we staff to. If we use averages like we did before, if you have an average of 100 patients arriving per day and you staff to that, 50% of the time you're going to be understaffed. So for every day that you have 75 patients show up, there's going to be a day of 125 on the other end, and you need to make sure that you can do that safely. So it's a balance of resources. If you staff to 125 patients all the time, you're going to be wasting time and money and resources, but you need to know when to do it. Oftentimes people will try to staff to the 75th, 80th percentile to make sure that we can account for that. On the other side of the coin is your staffing supply, and this is looking at the types of clinicians that you have, who they are, which is attendings. In academic sites, we have residents of all types. We have PGY 1 through 4, as well as off-service residents, PAs, NPs, medical students, understanding who they are and kind of what their bandwidth is to see patients. Knowing the limitations, one thing that comes in is didactics, duty hours, those sorts of things in terms of aligning your shifts is important to take into consideration. You use that to talk about the total number of staff you need. And then I'm going to talk a little bit more before I turn it over to Dan about productivity levels. First thing to point out is that obviously we're in May, so hopefully our academic departments are functioning at hopefully the most efficient that they are as this time of year, but a July in PGY1 is very different than a May PGY1, and you can see that the productivity actually changes over time, and you might need to up staff early on if your interns are seeing much less patients than they would as they're approaching a second year. I want to talk briefly about strategies to kind of do this, and one simple exercise that we've done is overlaying that patient supply curve, that demand curve, with your provider productivity. And one of the concepts we commonly use, which comes up in negotiation and all things, is your patient per hour. So we will look at that and see how many patients at a given hour can we see, and does this match? If we expect to get 10, 12 arrivals per hour during these hours of the day, do we have enough capacity to see those patients? And so we'll look at those and talk about defining our productivity, our capacity. So, our second year residents, when we looked at this a few years ago, would see 14 patients on average. Obviously, there's swings, which is like 1.75 over an 8-hour shift. And so we could layer these over, your patient arrival curve. So saying at 7 a.m. we have one second year, one first year, and you can kind of visually understand where you have unmet demand and excess capacity. So it's really important to kind of do this exercise. One caveat to this is when we did this didn't actually match up with kind of our lived experience, which was that at the end of the day here, the overnight team was usually getting more crushed, to be simple. There's a lot of patients waiting for them to be seen. And when we had dug into the actual description of how work gets done, the productivity, while we say it's 1.75 an hour, that is not actually true. There's a lot of variability by hour of shift. So that's really important to understand that and to dig into that data if you have it as you're making these staffing decisions, is that patients don't see 1.75 every hour of the shift. They usually come on, they're fresh, they see 3 to 4 an hour, and then as those patients get CAT scan results back and consultant recommendations, need procedures, they are seeing less patients. And it averages out to that, but it's more of a stepwise decline in productivity over time. And if you don't, you probably all have experienced this, if you don't take advantage of that productivity early in the shift, and they have a slow first few hours, at hours 7, 8, 9, 10, your resident's not going to then see 3 or 4. That's kind of wasted capacity. So when we kind of reran those numbers, and that has been borne out in studies looking at attendings, residents of all years, PAs, NPs, of showing this decline. So it's really important to understand that there's variability even within that productivity metric that we all care about and talk about a lot. That's just APP. So when we ran that number with the kind of that staggered approach, that's kind of declining productivity, we found it matched more what we were seeing, which is that the overnight team, even though we felt like we had adequate capacity in like the 7 to 11 p.m. range, there was a lot of people waiting to be seen, and this kind of matched up with other sources of data, looking at door to doc times, like we had just talked about in the last example, seeing that 7 to 11, even though we have a lot of doctors there, they're all busy with other people, winding down, trying to get prepared for sign out, that maybe we need more people kind of coming in at that time when they're fresher and they have more capacity. So if you have a good understanding of granularly what happens at each hour based on each member that's working in your department, you can kind of smooth it out. And what we had done personally at our department is kind of smooth out your shifts. Instead of having people arrive, multiple people at the same hour, we were kind of staggering it by 1 to 2 hours each time to take advantage of that that capacity. So those are just some general concepts, and I'm going to turn it over to Dan now to talk about some additional models.
So what Brian talked about gives us sort of a general idea of how we can look at the data that's coming in and make sense of that and make staffing decisions that make sense for our facilities. I want to introduce a couple of additional ideas and talk about what we can kind of expect when we're putting this into operational flow. So at the most basic level, we're rostering. So even the lowest volume ED is going to require 5 FTEs of staff to provide this 24/7 coverage. So even if you're seeing 10 or 20,000 patients a year, this is what's required. There is variability in terms of shift length, as Brian mentioned. So the longer your shift, the fewer patients you're going to end up seeing per hour, but that might work for certain shops because they might be low volume, or they might be low volume at certain times of the year. So you can change shifts to be 24-hour shifts or 12-hour shifts or whatever it is that makes sense. And then as you move into higher volume times of the year or higher volume times of the week, you can shorten up those shifts, give yourself more flexibility. There's also discussion around how you overlap those shifts. So Brian mentioned that for residents, if you have a lot of staff working, you can bring them in at different times of the day and try to optimize for that. But you may not have staff to do that. And then there is the effect of sign out and how you build your culture around sign outs. We've done studies looking at the effect of the sign out patient on productivity. And it turns out that more patients that you're signed out, the fewer patients you're going to see primarily. I think we've all lived this experience. So if you're looking to squeeze additional productivity, fewer sign outs is certainly one way to do it, but that comes at the expense of potentially being there later on shifts. There is a lot of thought in terms of the approach to wellness and how sequential shifts work. And so this has been an area of interest for our group at Beth Israel as well. And we've actually studied how do providers do when they work sequential shifts. It turns out that while they may not like working sequential shifts or sequential overnights, it actually has no impact on the number of patients that they're seeing. So we showed that residents can work, 3, 4, 5 overnight shifts in a row and see the same number of patients. Again, that doesn't necessarily factor into how people feel about working those shifts or more patient-centered outcomes. There's also consideration around how you approach call. So call would be the backup shift for somebody who calls out sick. So you could have a fixed call pool versus an incentive call pool. Somehow this needs to be paid for because it is work that people are doing when they have to be in town. So some places will have everybody pay into a call pool. Some places might just give an incentive rate to try to get people to cover those shifts. For smaller groups, it's going to be harder to have a fixed call pool if you're working with a smaller group of attendings and need to cover all that time. We talked a little bit about seasonal variations. So for beach resort towns, they're going to upstaff in the summers. For ski destinations, they're going to upstaff in the winters. Some places will upstaff for sporting events, holidays, things like that. There was a study that was done through a group where they looked at the effect of Patriots games on ED volume. It drops during the game, goes up after the game. And then there's deploying split flow and fast track processes to try to smooth out those curves and get patients seen at the right time for the volume of capacity that you have. There's a lot of study of looking at approaches to reduce left without being seen rates. So providers in triage, it's a great way to reduce your metric for this, but it doesn't improve time to disposition for the vast majority of patients unless you're discharging from triage right away.
So I'm gonna kind of counter that point, right? One of the biggest challenges with length of stay is providers is not getting the appropriate order stuff in on time and then adding on during their stay, right? Well, basic chemistry's up. This guy has a CAT scan now that I've seen him. So I think one of the things that the PIT process, the provider triage, it allows the physician or the to see the patient and put the appropriate orders in, so we're not adding on end of the shift. I think that would actually help the length of stay as opposed to,
Yeah, it's just, your point is well taken, right? So this is all about implementation. Can you do provider and triage in a way that improves your length of stay? Absolutely. In a lot of studies that look at the effect of provider and triage, if you're having somebody put in orders, not take a full history, shotgun a whole bunch of labs, be more conservative in their workup, and then have that patient go back to the waiting room and sit, that's not necessarily going to improve your workflow. So I agree there are ways of doing this that are going to improve your outcomes. It is not a simple solution to the problem, and it certainly is not something that can be deployed everywhere and they can say, yes, we've now reduced our length of stay because we have a pit doc. Could they? Certainly. But it's just by doing it, it does not necessarily do that. Again, and if you have PA and triage, and studies show, certain PAs are going to test more than their physician colleagues might, for example. If you're then doing a big workup on low-risk chest pain, again, you're going to impact your length of stay in that way. But point is well taken. There's a lot of studies looking at vertical care, results waiting room, and moving care into the waiting room. This is an article that was published as a sort of a satire in the Canadian Journal of Emergency Medicine back in 2007, pitching a fellowship in waiting room medicine, which seems to have become all too often the reality of how we are practicing these days. Transfers are a big part of how we staff. So this is a study that we did at the Medical Center looking at the volume of transfers over the course of the day. So transfers are going to make up a disproportionate amount of ED volume over the evenings, and so staffing with the understanding that that's part of your volume. It's not just the patients who are walking in who are there. It's also those who are going to have disproportionately high resource utilization who are coming in on the overnights, and the consultants and imaging needs to be ready for that. And then there's consideration of, do they have to be transferred at all? So can we build capacity for community hospitals and within networks to get more specialty coverage, to do teleconsultations, to do round-trip transfers, and then try to direct them to inpatient beds when they do have to be transferred as opposed to coming through the ED when that makes sense. I think it's important to understand what the expectations are for our residents over time. So Brian mentioned that we are in May working at sort of peak capacity at a lot of centers as residents become increasingly independent. So it does not progress linearly. So this was a study that we did looking at patients per hour over the course of training. And for interns, pretty much progressing pretty linearly, and more senior residents can be more responsive to volume, as can attendees. And residents and attendees are resilient. So this little blip here is COVID. There was a big drop in patients per hour that was seen at that point. Residents bounced back. We're back to sort of the same productivity levels despite that blip in training. Faculty also are part of managing the productivity. So academic-only faculty might be employed. There's also hybrid approaches where faculty are both in the community and working at academic sites. And this has the advantage of increasing the faculty pool that you can draw from. So if you have more shifts, you can then have a larger faculty group. It's a way of creating a larger academic faculty. Also has the benefit of often improving compensation among your faculty group if folks are working in the community as well. And it's important to note with all that academic faculty are not necessarily the same as those who are working in the community, so they might have different interests, different different research priorities. And then finally, we'll get a little bit more into pathways and process development a little later on, but faculty are not all the same, nor are residents. They test differently, they admit differently. This was a study that was done looking at the factors including likelihood to admit, likelihood to consult, and likelihood to image. You can see that there is a range of high utilizers up in this corner and low utilizers down below. And I think generally having some range is very reasonable, and this only starts to become a problem when you have physician outliers that start to break the system. And I think many of us can probably imagine the doc that you come on afterwards and all of a sudden you can't get a CT for 4 to 6 hours because everybody in the department is getting a CT or everybody is getting admitted. And so as operational leaders, it becomes important to say, is this person an outlier and what can I do about them? And if so, managing that behavior becomes important rather than trying to dictate specifics. Pathways and decision tools can lead to less variation, and as you're trying to work on that queuing curve, that can be really helpful for staffing appropriately and making sure that there's less variability between different care for the same condition. So in conclusion, we've talked about queues and the fact that they increase exponentially. Physician capacity cannot be stored, so if you're not seeing patients at the beginning of your shift, you're not getting that time back. So thinking about how to staff to that level is important. Staffing to average misses half the time, and I feel like this is a big conversation that happens with a lot of C-suite folks around compensation and around efficiency and saying, well, you only average this many patients per hour, why do you need all these doctors on, for example? But if you staff to the average, you're going to have exponential waits half of the rest of the time, which I think is unacceptable for most of us and unacceptable to our patients to encounter that. There's a lot of fine-tuning that can be done for staffing to try to get that capacity at the right places by tweaking shift length, tweaking types of residents, and then it's important to just know what to expect from our residents and attendings as far as patients per hour. When are they seeing patients during the shift? How are they working them up? And is there room to improve efficiency within their workflows? So with that, happy to take any questions that folks have. Yeah.
Do you have thoughts on how to approach physician variability when it comes to testing and imaging? And like, if we find transparency and, showing people their individual statistics and where they lie is helpful?
I think there's a lot of additional experience in the room, so I'm curious how folks have approached this, but I think that showing the data can be really powerful. And then standardizing how we work up patients by employing pathways can be also really helpful. So if you have a chest pain pathway or things of that sort, that can be useful. D-dimers are really, there's a ton of work on D-dimers and just really pushing the use of D-dimers prior to jumping to CTAs and trying to show that that is an effective way to work up patients. And it seems a little trivial at this point for folks who are really comfortable doing it, but that has been shown at a lot of centers to be something that folks are not comfortable with or weren't comfortable with. And so deploying a validated, like EMR-based, yes, we age adjust this D-dimer, pathway can be really helpful for reducing CT utilization, for example. Curious if other folks have thoughts on.
And you're still going to have a lot of variability. I think, like Dan said, having the data and showing the data is going to be really helpful. I think a lot of your staff may not know where they live on that curve, and they may think that they are an under admitter or an over admitter, and they really don't know. And having that and showing, our group C, admits at a rate of 20%, and you admit at 28%, and that is standard deviations above. Maybe start like having these regular, bi-yearly check-ins to see what they're to see what they're doing and see if they're making progress towards that of their rates. Maybe they're admitting scanning too many people. There's still always going to be the extremes, and if that's a pattern, then you at least have had that demonstrated, and you can kind of dig into that individually. But I think most people are trying to do the right thing and want to course correct and don't want to be too far out of line in one direction or the other.
Yeah, I think a lot of places a little scared to like just be transparent with data, right? Like, I think a lot of places like they'll tell you what you're doing, but they'll mask everybody else. And I think culturally, that's an issue. Just the more data you share with people, the more honest you are. I think that you can have like an active conversation what's going on. And I think the caveat is like different people have different set points of like, their level of comfort, level of risk and all that. So you cannot to some degree expect that everybody will be able to kind of like do exactly the same thing. It may just take you, a greater number of scans for you to feel comfortable about, kind of working out with the seas than somebody else. So that's neither right nor wrong. But, just by sharing the data alone, you can bring some of those outliers closer to like the mean of your actual group.
So what I want to add to that too would be like countermeasures too, like, right, admission rate, you're getting less, what are the, or like there's just starting quickly, how often are they coming back? And so in our dashboard, if you notice, it's helpful to segment where you see, actually, we are discharging quicker, and their 72-hour returns are not increased, and that also can be reassuring for your physician colleagues.
Yeah, I think one of the things that physicians are really terrible at is holding other physicians accountable in the group, right? At least from my experience. I think having data and sharing that data is really valuable and having some level of accountability, right? We have nurses who expect to see 4 patients when they're working, and right, they have 4 rooms, and just because you're slow doesn't mean you get 2 rooms. If you're fast, you get 6 rooms. Everyone gets 4 rooms, and yet from the physician side, like we have the variability from the people we see in our room see 1.5 patients an hour. Somebody who sees 2.3. Well, if you're receiving the person before you receives 1.3, because you're going to come on and you're going to be working even harder to play catch up. But if you're receiving the person who's faster, then your shift may be easier. So I think there has to be some level of accountability. But having that objective data, I think, really helps. Really helps in course like, hey, listen, you're 1.5. Your colleagues here, like average about 1.8, 1.9. What can we do to, and a lot of this is education and really just knowledge. I think it helps that knowledge. We started doing that about 6 months ago, and our length of stay is dropped by almost 20, 30 minutes in just a 6-month period. Because people are like, oh my God, I'm really that far off. But I think knowledge is really important, knowing where individuals stand.
Yeah.
So I think a lot of it is how do you incentivize it. And there's financial incentives and non-financial incentives. So we use like a DDOM CTPE and a Canadian Nexus rule for basically low acuity head CT to try to reduce those things. And we actually link those into our annual physician compensation, is that your compliance with those tools are a small but not meaningless amount of the incentive pay gets. They do it, and people pay a lot more attention. Like, certainly you need good data, you need to be seeing it every month, you need to sort of believe in it and that it's transparent. The other avenue we took, because you can't financially incentivize everything, was recognizing, especially with the large variability in patients per hour, that fair is not always equal and equal is not always fair. So that we basically took our shifts and broke them into 3 categories of shift. The teaching critical care shifts that everybody wants to do. The physician and triage shifts, where we really want to put our fastest doctors there. And then the shifts that didn't fit into either of those categories, our observation unit shifts and some sort of built-in less efficient unit shifts. And what we sort of were pretty transparent about and built out to our group was to say that nobody is going to gain or lose teaching critical care shifts. If you're really good in triage, we're not going to punish you for being good by taking away those shifts. If you're really bad in triage, we're not going to reward you by upscheduling you on the shifts that you actually want. So we're going to hold sort of the triage and the less appealing shifts equal. And we're transparent that if we're upscheduling, if we downschedule you, we don't ask. We tell you, we say, hey, for this 3-month period, you landed in this group, and you're going to see a schedule manipulation that occurs. If you are in the up group, we made it optional, so we reached out and said, hey, like, you're one of our top performers, congratulations. Would you be okay with us putting you in the higher performing group? Here's exactly what it means. In the 6 months we've been doing it, we only had one physician decline inclusion in the higher performance group. So just another way to think about it. You can pay them directly, or you can find a sort of non-financial way to try to be there about it.
Yep, I love that. I think the idea of as long as you're including people in that decision and giving them sort of the big picture what they want, that seems great. And I think anecdotally, people who are fast in triage or whatever enjoy doing that, and those who are not probably don't enjoy it as much.
I have a question.
Why don't we start with you? And then,
I was just curious, will you talk about the pros and cons of the different staffing models, like for like versus hybrid, something today?
not beyond. We can talk about it during our panel, but not beyond what we have here. So I'm happy to. We can talk about it now. We're coming up on break time, so I want to be thoughtful about that. But
We can definitely make that a question for the panel.
Yeah.
We've got everybody up here.
yeah. All right, Jamie, was there? All right. So we have a short break now. Happy to discuss other questions if folks have them. Let's plan to take 10 minutes and be back to resume afterwards.
Sounds
Cool. Thanks everybody for the awesome conversation.
I apologize, I'm an absolute pedant. There's a slide here when you start with the wrong door, and also the slide where we talk about missing time. I think it's like 16 hours wait time. I'm gonna speak in full sentences now. I apologize. At some point you mentioned the perfect efficiency model.
Yeah.
But even if someone's going at perfect efficiency, you said that still ends up being like 4 hours of wait time.
Okay. Yep.
I did the math because that's what my brain does.
No, what,
It's 16 hours.
okay.
Yes.
Yeah, what I was saying in that, some fuzz, no worries, but if like, your nurse is gonna see all 10 patients over that course of hour, that's perfect for her. But all of 10 of those patients arrive right at the first hour.
Yeah.
Then the first person waits 0 minutes, the second person waits 6 minutes.
That's what I'm saying.
16 hours.
It's 16 hours. I did it long and then I did the calculator because it's 9 people wait 6 minutes, 8 people wait 12 minutes, 7 people wait 18 minutes, right?
You're talking about this slide?
Yeah.
So you want the
Pretty sure I am
decreasing series.
Well, the longest person waits 54 minutes. And then, yeah, 48 minutes. Yeah, 50. It's 54 plus 48 plus 42.
58 plus 48, 54 plus 48 times 2.
No,
2
just,
people are waiting 48 minutes.
but one of those 48-minute person is the 54.
No, you're right.
Yeah, it's 54 minutes plus 48 plus 42 plus 36 plus.
And actually, it's my boss.
No,
No, no.
it's many hours. That's the point is that it's a lot. And that has to be one build it up.
Yeah, because you can't, you have to add 6 each time.
Yeah, so it's 54. It's like 4. Between 4 and 5. Pretty sure.
Yes. No, you're right.
I would, so I.
I'm trying to figure out how you got to 16 hours with that. So you're absolutely correct. You're gonna average out at 20. Yes.
Yeah, so the average person, the total time is over 10 people is 27 minutes. Some people wait 0, some people wait 50. There is a lot of fancy online, like high-level statistical calculators for these that it's fun to like dig into. What?
Oh, so too.
For these, yeah, for these ones, but if you're talking about if you have like multiple triage model, say you have 3 nurses, they see an average of 8, but the standard deviation is between 2 and 10 minutes. You have patients that arrive, you have an average of 10 an hour. It's very
days between 6 and 7, and it's different minutes. There's a lot of variables that are.
At what point do you find the granularity becomes unnecessary? Like you mentioned that like it was mentioned that it's better to like have data not for shift before out what figure out these
For the staffing aspects?
well, for almost anything, do you find that there's a point at which like second by second isn't gonna
Yeah, I think second by second's too early. I think usually by, and I think that's helpful with us. It's easy to digest that, and most departments will have that kind of whale's tail that shows things start to pick up in the morning, peaking from like 11 a.m. to 11 p.m. and then they slow down overnights or less busy. So knowing that, that's why nurses staff is a lot of 7, they have 11 to 11, they have 11 to staff certainly. So making sure that we have enough physician staffing at each of those hours, figuring out when those patients are like ready to be seen, like how many patients are put in. If you don't employ waiting rooms, I see on the pictures of waiting room. If you don't employ that,
New York as far as I've seen.
yeah, so it's like they're only ready to be seen when they're brought when they're in treatment space. So looking at like, how many patients are put in a treatment space newly between each hour, and then do you have enough staff ready at that hour that are theoretically capable of seeing that? And there's variability. We can say doctor, a certain number of patients on average, but obviously it's all 2.6. Those variability. And if sick patients come in at the end of at 6 a.m. for an overnight shift, and two really sick patients coming back, they're all going to get seen. Versus if like maybe someone comes in at 6:30.
Looking at the accuracy of CSI,
So
the actual ESI.
generate
So like the actual, well, yeah, no. I think there actually has been a study looking at like the shifting ESI 3 and ESI 5 is like how many resources are actually used. We have the data to actually say how many people with ESI 4 actually require like meds and an X-ray or whatever.
which is like a terrible shift for residents. It's like really functionally an overnight. So we made it an attending only shift. So that if the overnight team comes in, there's 20 to be seen. There's just
And we could also do all of the distributed stuff on top of that too.
So we would say, well, they're going to see, we expect them to see 2 an hour on average, but they'll probably see 8 patients in those first 9 patients in those first 3 hours. To cut it in half, and try to get everything handed off. Yeah, to sign up to the overnight team. And we would incentivize it. If anyone wants to work in a functionally at an overnight shift to 4 a.m., so we have to tie some dollar amount to it or make it more.
I have like what is arguably a big project. So I talked to Alma.
Yeah, so it's a short shift. Basically, we have
about doing like
basically it's written in our schedule.
on like informatics and
But
it's like we could
then
do it.
by midnight,
It was like
other teams have signed out.
I'd be gives me a amount of work that it is to actually edit.
There's still 20 patients to
And
be
you
seen.
can only be an author on like 2 of the papers. Because like it's hard to stay paid.
They can't just dump 30 So like you have like certain criteria.
Like you can see
At midnight, there's a certain number, then they can
7 or 8 of them. And it's like you're still going to do the same amount of work.
usually like
But at least get lots of
the hard stop is like
like
2.
way more articles.
But you can sign out early. If I come in and I see 10 patients in 3 hours, and
Oh, so that's what I did. Basically. So now I have like
there's only 3 patients left to be seen at midnight.
so for
Still 10 to be seen.
and he was like, yeah,
Or on my list, there's still a bunch of people that still don't have.
but that also means that it's like you have to
You
corral.
can't police it perfectly, but you can like set some guardrails so certain bad actors are picking up a lot of patients, ordering like MRIs on everybody, and then saying, "They see it." And, like,
So you hope that there's some amount of just like personal
you have to assume that. In fact,
and is that a mandatory shift or is that a like people can?
we started it off as a we ask people to sign up, just because we know that it's a crappy shift, but we financially incentivized it, and usually the people are Some of the older faculty don't like it. Some of the new faculty that want to make extra hours. Like, happy to pick it up. They like go work in the straight. So we do that. If it doesn't fill, then it gets realized.
That isn't, it's not built out of like a want for efficiency, it's built out of a, we don't have attendant coverage for that day, and our shifts are weird, and so there's a 3 hour gap. And it's always pretty, and it's never an assigned shift. But for anybody who is living in the city and doesn't have like a strong feeling about Sundays, it's a lovely way to spend 3 hours without messing yourself schedule at all.
Yeah, so you have to take that into once your staff is your staff, you know, to do that. If I have 2 kids. When I was younger, I was like, I'll just work whatever, I don't care. And then when I have 2 kids, it's bedtime for the section. Yeah. So you have to kind of have enough diversity. People's where they are.
Sorry for doubting your math.
I offered. Like an offer.
Yeah, man. All that work is fall apart.
They defended my math.
16 and a half hours.
What?
It's 16 and a half hours.
No. Okay, 10 people that show up. 10 people show up. All right. First person wait 2 and 0. The next person wait 6.
But 9 people with 6 hours. If they all show up at once.
Yeah.
Yeah. So yeah, 9 people should play. 8 people would get 12.
No, but 8 people wait 12. 8 of those people are so if one person waits, if you take one person waits 0, one person waits 6, one person waits 12, one person waits 18. So the longest waits 54. So 2 people wait 48. One of those is 12. So it's 50. All of these are. Basically, at 54 plus 48, I did it. Simple percent. I don't know coding, but I have.
I'm impressed that her first thing was here. It's math.
Well, I have. Oh, cool. Hey, nice to meet you. Brian. I worked with these folks long time ago. I mean, 5, 6 years ago. Yeah. So I've done a lot of I didn't need them. Yeah, so I'm like 50-50. Yeah, I need them. Yeah, it's even more like ruthless than that. It's like collections based. It's collections based. So. I have a lot of thoughts. And it rewards you for like a terrible shift. So if you come in and you see a really busy shift, you like make more. You like at least get compensated for it. So I moonlight like some other places where I'm hourly, and I'm definitely like not as motivated. If I'm at like CHA, I'm not gonna. I could see half the amount of patients, and it wouldn't change. Yeah. So there's a balance. I like parts of it. I think it makes negotiation and recruitment difficult because like you are what you make. Like there's no like packages. I can't go like, hey, I got a better offer here, raise my salary $20,000 or I'm gonna leave. They'd be like, the money is the money, leave. So there's a stipended system. They're like, yeah. So basically there's all the money is put into a pool and there's like a collective tax that is what is the department value. So program director makes X amount of dollars, associate program director, operations, ultrasound, tox, and they've assigned a dollar value to that. So that is like that is the negotiation money, and it's just like who controls that is like the higher ups, which I am not a part of. I think that's the rub.
But in terms of like being able to flex up or flex down your schedule, there's nowhere you know, like schedule like 3 months in advance or something.
Usually 3 months, yeah. Like I've had times where I was like traveling and I was like, just move I don't want shifts that month, and someone will pick them and I'll take a little salary hit and I'll pick up extra shifts. So,
Yeah, because so long as you're like reasonably close to your salary target for the year, like people are eager to flex up or flex down.
Yeah.
So it's right, as opposed to like with moonlighting where it's sort of like a vague like per hour stuff that gets tacked on at the end of the year or something like that.
yeah, it does. It's nice to do that. Yeah. Yeah, they try to assign it based on like based on what you want in your complement. It's like it would be rare circumstances in like COVID when like there was some variability. But they try to keep it assigned, but people do pick up, and usually like the people that have a full complement of shifts that have a lot of administrative buy down, whether it's like hospital level stuff, are usually like the ones that are like giving away shifts left and right, and it's usually the younger faculty that are like, I want to teach more, I want to like work more and make that money directly, and so pay off loans. So who wants money? Who wants money? Yeah. Like I've almost always been able to give away a shift, or I usually swap, but it's almost unless it's like the Saturday overnight Memorial Day weekend or something crazy thing like that.
Yeah, no, I'm gonna do the walk around thing too.
All right, so we're gonna get restarted. During the session, have a nice break, go out for stretching and watch the water. If anyone needs water, it's like literally right outside.
I think you've probably seen these slides like 15 times.
And I'm Wendy Connor, the Executive Administrator Fellow at Yale, and I have Dr. Ben White here. I don't know if you wanted to introduce yourself too.
Hi, my name is Ben White. I'm the Director of Patient Experience for Mass General Brigham Emergency Medicine, and I run a small center for emergency medicine innovation.
Great, and we have no conflicts of interest. All right, so why does patient experience matter? So it leads to better health outcomes, and it also leads out that we report with your patient, they're more likely to adhere to your medical treatment plan, and that leads to better patient safety. As well, there's been studies that show like increased staff satisfaction as well as decreased clinician burnout. In addition, there's definitely regulatory incentives as well, where having these great patient experience decreases the number of patient revisits come in, as well as reports to DPH. And lastly, there's also some financial incentives tied to that as well, with patients like there's patient care, they're less likely to sue the physician more possible, and that leads to a reduction in malpractice risk, as well as there's a payer bills too, because sometimes patient surveys will lead to looking at incentives. And so why are we talking about clinician experience as well here as well? So it's because emergency medicine is, I'm sure a lot of you have seen, and the Medscape survey back in 2024, emergency medicine is one of the most burned out fields. And why is it a real stress clinician experience involved? Well, there's been a huge number of studies that show that with patient clinician experience is also tied to patient experience, and they're kind of, so, these are just a couple studies that show that. And so when we think about the clinician experience, one model that I like to use is the Stanford model, professional fulfillment. So there's three main pillars, one being culture of wellness, personal fulfillment. But as administrators, one thing that we can really target and focus on is efficiency and confidence. And so one kind of takeaway point that I want to bring to them today is think about your last shift. Raise your hand. Did you have, were you working while you were working? Did you have or encounter something where like, gosh, I wish that was easier? Whether like you encountered a printer maybe that was broken and you're trying to fix a paper jam or something like that. I feel like I've encountered a couple of those. And so one thing that we can make experience better for the clinicians is designing kind of like a frictionless meeting where when we work in our clinical environment, things, the small things where we can call pebbles in our shoes, that gets fixed. So something we kind of implemented at Yale is that we actually have a care signature board, and anybody, including nurses, techs, even clinicians, can submit things that they encounter during their shift that they can quickly improve. And so this board is surrounded by, and of course, like in any initiative like that, it really takes collaboration with the nurses. So the APSMs actually round on the board and take down all the thoughts. And so a lot of the major things that we encountered, there were a lot of concerns about what encounters with technological related issues. How people are out, sometimes we're out of toner. And instead of spending that time trying to find a toner, fix a printer, we actually now have a dedicated APSM or tech. If you encounter that in your shift, instead of shifting your focus from clinical care with the patient, you actually just let our APSM know and they're able to fix that. And the same applies to kind of like other interventions. For example, when we change our zones from like a larger zone into two smaller zones, we quickly got feedback that, hey, my work experience is a lot better if Epic reflects that new change. And so within 24 hours, we were able to, fix that and kind of improve clinician experience. So that's something to consider. Well, to walk, as a couple of our shoes, we would certainly walk, with more better experience and would walk further if we, don't have any problems there. So as key takeaways to take back to the emergency department. And now I'm going to switch and turn over to Ben.
It was so fast.
I'm efficient.
Yes. So, hi everybody. So we're going to switch gears slightly to a more interactive session. We're just going to do a few more slides on background. But one thing I just want to start with is the typical disclaimer that this is not a collection of slides about turning your ED into the Ritz-Carlton, which is one of, I think, the main areas of challenge with talking about patient experience, which is that a lot of us, I think, as emergency physicians who want to focus on the patient and do what's best for the patient, tend to think of parts of patient experience as a little less important. Because in many ways, some of those aspects are a little less important than saving someone's life. Full stop. But I will say, having now tried to convince folks for more than a decade about the importance of patient experience as a topic, the idea of the flip side of the same coin that you just heard about, with a patient who's in a better space, making your shift better and back and forth, and the 60% burnout piece, is really a strong motivator to think about some of these potential interventions as benefiting both you and the patient. And my argument used to be, and the literature supports this, that patients are more likely to do what you ask them to do, they're more likely to follow up in the way you ask them to do, to take the medications you ask them to take, and there is a patient outcome benefit to improving patient experience. But if the main sort of what's in it for me motivator for you is that improved patient experience will mean that you're more likely to go home and feel good about your shift, that is totally fine. And so With that, I just want to bring up an equation for happiness that I have loved teaching about, and I just think is so relevant both to patient experience and emergency medicine, but especially to life, which is very simple, right? In that if expectations don't meet reality, your happiness decreases. And yes, you can have all the perspective in the world, but when you think your flight's going to leave on time and it leaves an hour late, right, your reality is not meeting your expectation, and it is a challenge to your level of happiness. And so, if you're going on vacation and you expect Hawaii to be beautiful and sunny, and for 4 days it's raining, right, you can be as balanced and centered and Buddhist about it as possible, but it is still likely that you're going to be less happy sitting on the rainy beach. And so I use that as an example because I think one of the ways in which we have failed our patients is appropriately establishing expectations of what it's going to be like to be in a busy, crowded 2025 emergency department and all the other stuff that we've talked about this morning. So just think about establishing expectations as one option. The other thing is we have a pretty good understanding of what patients are looking for, and it's not kind of crazy stuff, right? They're looking for good staff-patient communication. They're looking to have as low as possible wait time. Not surprisingly, we all don't want to wait, right? And empathy and compassion, and a number of things that we have some effect over. And less important are things like the environment of care, right? It still matters, and we're going to talk a little bit about that as well. But some of the stuff that we want to do anyway as effective clinicians is what the patients are looking for too, in terms of their expectations. For what it's worth, this is a study that Jonathan Sotos and I published in 2017, looking at 1,500 different patient experience papers, right, and doing a systematic review of the literature. It was awesome. And so for any of you that are academically minded, if you haven't done systematic reviews of the literature, it's a really great way to kind of like establish truth for yourself. But in addition to that, I will say that a lot of the underpinning of that literature was this whole question of like, does it really matter? And this was back when a lot of the literature was about patient satisfaction, and the word satisfaction has a whole host of other, components to it. So just know that our patients are really looking for reasonable things that we are also hoping, I think, to achieve for them. The other larger concept that I'll just mention is that if any of the ideas that I'm about to sort of go through the top 10 list resonate with you, just kind of think about fitting them into a local sort of effort impact matrix for you, right? And if any of them fit into this sort of shorter term, lower resource, or even just do it box, think about those, because that can establish some degree of momentum that you're somebody who's like interested in helping patients and improving patient experience, and then allows you to build out a team. And that's been the sort of best thing for me. I was just talking to Josh about this over the last decade, is now having like a team of folks that are interested, and there are people that are interested in this, and like getting to have meetings where you're like optimistically approaching some of these issues can be really enjoyable. So with that, here's the top 10. The way we do this is that I'll put up a cue or a clue, and just, if you want to shout out what you think the right answer is, feel free. It's fun and interactive that way, but if not, and it tends to often be not, I'll just keep moving on. And then the other thing that I'll just throw out there is that the ideas are going to get more challenging as we go throughout the top 10 list, and also somewhat more resource intensive. But there's also an overlap with effectiveness, and you'll see that in the last few slides. Okay, so here's the first one. What are we talking about? Cleaning. All right, so improving the environment of care. So as I mentioned, this is not as sort of important as one might think. The patients are not expecting to come into your ED and have a Ritz-Carlton-like feeling. But look at this room, right? There is a level of you never get a second chance to make a first impression in the sort of cleanliness of a room. I would love to be cared for in a room like this. I can tell you we don't have a single room that looks anything like this at MGH, except right after we renovate a space, right? For the first 6 months, it's like, oh, there's no povidone iodine stains on the floor. It's awesome. But I will say that there is an improved perception of care quality that is established in the literature. And if you have the ability, one mechanism you can use is to take a room and do a deep cleaning. And so just take the whole room out of commission for a period of time that it takes environmental services to do a deep cleaning, and then just move that through a cycle. We had some success with that in the past. It's been a little less effective lately because we've been so crowded that we just don't have that time of day when we have an open room, right? We basically have hallway patients all the time, but just consider that deep cleaning idea. And then the other thing is decluttering, which in 2025 seems a little less of a problem in EDs, but all those papers that are hanging up that people just stick on the wall, or the example I used to give was the integral and dosing chart, which is no longer relevant, but all those papers that get tattered and are kind of not so attractive, you can just decide as operations leadership to just take that down, right? And just continue to take it down. And every time somebody puts up the most recent example was that we had Chlamydia Awareness Week, and all of a sudden there was a Chlamydia Awareness Week poster on it. Right, okay, that's coming down. So, there you go. What's this one? Food, right? Doesn't love a Big Mac. I'm not suggesting giving patients Big Macs, but there is the opportunity to work on providing nourishment to patients in most emergency departments. And we've fortunately had a really good relationship with our food service, and they have been interested in helping us to better meet our patients' nourishment needs. But if this isn't an opportunity, or it isn't like sort of an available option for you, there are vending machines that exist. And we had to black out the name of this one for SAEM, but there are vending machines that exist that can provide healthy food to your patients. And because it's a vending machine, you just need a plug and they'll take care of the rest, right? It is true that this confers cost to the patient, and so you have to talk about the sort of equity piece of having something like this available. But your staff can also access food through a sort of opportunity like this. So just know that there is literature that demonstrates that hunger exists, and we can help patients. I'll also say that one of the best sort of patient experience qualitative feedback pieces that I have read was a patient who was very, very highly agitated and just screaming out for a sandwich, and then got a sandwich and became this super nice, friendly patient for a sandwich, right? Not Haldol, but just a sandwich. So if that's an opportunity in your department, consider reducing hunger. How about this one? So similar to the Big Mac, this is not providing alcohol to your patient. It is improving comfort, okay? So there's a lot of different opportunities to help patients feel more empathy from us, right? And some of that is that we all just kind of want to be comfortable. And a lot of our EDs are not comfortable spaces, right? The temperature is off in a lot of our departments because it's managed centrally, or the spaces where we're asking patients to wait aren't the most comfortable. But a warm blanket is almost never harmful, right? Which means that you can provide a warm blanket as a physician, as a nurse, or even as a volunteer or a coordinator, or any of the non-clinical roles can be encouraged to provide warm blankets. So, unless you have hypothermia or NMS, like a warm blanket, great call. And so if there's a way to reduce the hassle bias for all of your staff to provide things like blankets, pillows, and just a little bit of extra comfort, it's a really great way to improve that perception of staff compassion and empathy. So this picture is not actually moving. But your perception is telling you that it's moving. So as you think about this idea of like what patients are perceiving and the reality minus expectations component of things, there is an opportunity to shift the patient's perception from feeling frustrated about their weight to being distracted, right? And one of the ways in which we used to talk about this a lot was shifting your waiting spaces such that there's some distracting thing. So like we learned this actually from the Mass TMV, which is the idea that you shift all the chairs so they're facing big TVs so that your patients are distracted by screens on the TV. But these days the conversation has totally changed because most of our patients come in with their own distracting devices, which is a whole other comment in society that I won't get into. But those devices are available to patients to distract them from their weight. Unless they're not charged. And so to the extent that you can work on this idea of sort of building out the ability for your patients to keep their devices charged and distract themselves, it's awesome. The other thing I'll just mention is that there are opportunities to distract your patients with value-added things, right? So we had a whole texting system where we were sending event-based texts from Epic to keep patients sort of involved in their care and to make sure that we were sort of maybe doing a little bit better job with establishing expectations, and we had a whole welcome video about our ED and that kind of thing. That was a bit of a heavy lift, but even just basic texts can be helpful to kind of continue to engage your patients and distract them at the same time. And I will also note, for any of you that use Epic, there is an awesome new functionality in Epic that is basically a build out of the patient gateway and my chart interaction with Epic called My Chart Bedside for the ED. We just went live with it 2 days ago on the 11th. I think that was 2 days ago. And it is a value added way for a patient to be involved with their care and distracted in that they can, sort of interact with their chart and their record and their results and a whole host of other functionality. So to the extent that you can reduce the patient's perception of their weight, and there's literature for that too, by distracting them, it is a highly valuable intervention. We're getting a little trickier here. Joking, this is not tricky at all, right? So, pain control, right? So pain control makes a huge difference and is one of the sort of areas of feedback from our patients that's kind of hard to argue with, right? That like, I was in pain for 8 hours and nobody did anything. For the patients that are actually in pain from their renal colic or their appendicitis or whatever, it's kind of a bummer when that's the feedback you get. And if you've ever been a patient in pain and had to wait, how many folks have been a patient in pain and had to wait? Right? It's kind of like the most basic evidence of a system that doesn't really care about you. So to the extent there's a way to optimize pain control in your department, and yes, this is a more complicated conversation now that we've shifted from oligoanalgesia to the opioid crisis and now back to oligoanalgesia again. It is a valuable thing to at least think about those patients that are in the most significant pain and try to address their pain concerns sooner, whatever that means for you. I will mention that in our department, we had a code pain approach. It was actually suggested by our nursing leadership, where patients that endorsed a 9 or 10 out of 10 pain had basically a different approach to managing their pain, which was moderately successful. Would you agree with that summary, Brian? Moderately successful? Yeah. Anyway, it's worth thinking about. Okay, how about this one? Doesn't he look so empathetic? He looks so kind and thoughtful and caring. So empathy and compassion is a very difficult, sort of large topic to address, especially in busy emergency departments where we are stressed for time and people come in with all kinds of different ways of approaching patients and care. But just know that there are training options that exist. So if this is something where you feel that your staff might benefit from at least a sort of a shift in focus a bit towards demonstrating the empathy that many of us feel towards our patients and having just a slight shift towards being more compassionate, in the era of what is very clearly established as compassion fatigue, likely in the setting of our very busy and crowded emergency department, just know that there are training options. And this is one that I really like because it's very easy to teach. And it allows people to sort of think about some of the basic stuff, like making eye contact with your patients, or your body posture and position. And then that allows you to talk about sitting and how important it is to sit with your patients, and the fact that if you sit, patients perceive a 2 to 3 times longer period of time that you've spent with them, right? So sitting is like so easy and basic. You just need the chairs, and you need the chairs not to leave the room, right? We had this whole intervention where we had lavender colored chairs, totally ugly chairs that were for one part of our department. And the idea was they will never leave that part of the department. And I sat on one 2 weeks ago in the complete opposite side of the department. I was like, okay, so much for that intervention. But just know, sitting, body posture, eye contact, they're all things that can be trained. And for anybody who wants to dive a little bit more deeply into this, Helen Reese has a really great TED Talk YouTube video. She has now built out a company called Empathetics, which is incredibly expensive, but and I'm not endorsing it, but the YouTube video, the TED Talk, is great for this. On a similar theme, so communication, right? So as mentioned earlier, staff-patient communication is at the top of the list in terms of what patients are looking for, and quite frankly, likely has the most overlap with patient outcomes that we're desiring. So to the extent that you can support communication whether that's with a sort of training model, and there are a number of them. This is the one that we like because it definitely, calls out the importance of introducing yourself, which many of us forget to do in the setting of being busy, and setting expectations at the end of your discussion with the patient, right? And if that happens more frequently throughout those episodic interactions with staff, patients feel better about that wait period in between either the initial evaluation and the diagnostics, or the diagnostics and the disposition, or the disposition and the many, many hours that they wait for an inpatient bed. So setting expectations is really key. We like the eye care model, but the other thing that is a lower lift and is actually, quite easy to get through the multidisciplinary committees is just putting up signage to support communication. So agreeing on what it is that you want your patients to hear can be a little tricky, especially when patients want to know how long that CT is going to take, and the estimate is anywhere between 2 and 17 hours. But the idea of hanging up a sign that says, if you want more information, you can go to this website, and there'll be frequently asked questions, or you can find, other components of, sort of questions that you have. And again, my chart bedside is going to be great for a lot of this. And also signs that sort of help your patients to understand that there are stages in the care, and to sort of be prepared for those stages. Can be both helpful to the patients and also for your staff, because it sort of unyokes the need to make that communication happen. This is one of my favorite studies in patient experience, which was from when it was still called patient satisfaction. So this is the idea that if you study 1.525 million patient visits, that there is a very clear interaction between the amount of time somebody spends in the ED and their likelihood of feeling good about it, right? Which I think is just human nature. It's true for all of us. We don't want to wait for stuff. But once you get to 3 to 4 hours, like, you've lost 20% of your positive patient experience feedback, which was studied in a different way than the way a lot of us use or measure patient experience now with the Net Promoter Scores. But you can imagine that relationship is probably pretty similar. So to the extent that it is possible to either use lean methodologies or queuing theory, or a combination of queuing theory and shifting bottlenecks and all of the sort of operational stuff that can allow you to reduce wait times, it is very likely that you will see your scores improve, and there is literature to support that. All right, so this is finishing strong. This is the idea that you want to help your patients leave with a good taste in their mouth from the experience that they had in your department, right? And a lot of us, I think, or at least my experience has been, that discharge is kind of like the end, right? We're just like, okay, you're good, you're done, we can let you go now. When having a really good discharge process and an efficient and effective discharge process can not only help likely improve outcomes, and again, patients are more likely to follow your discharge teaching, but can also make the patient feel like, oh yeah, despite all the chaos that I just went through, I have a clear plan, I have a clear collection of answers, I know it's not this, and that kind of sort of emphasis on discharge can be really effective. So again, if you're going to do the signage move, you can have some signage about discharge information and sort of preparation for the patient in terms of discharge. And then depending on what EMR you use, if the way in which your discharge summary is being generated is not what you want, you can ask them to change it, right? And for any of you that use Epic, it is challenging to work with Epic on the AVS, but it is possible to optimize some of those things. So just know that that's an option. And here is the last, but at least in our department, the most effective intervention that we've done. So this is a callback program. If you have the resources to do a either nursing-led or clinician-led callback program, it can be incredibly effective on a number of levels. So the literature suggests that to the extent that you care about the overall likelihood to recommend question, which is what many of the sort of patient experience surveys use as the summative measure, how likely are you to recommend this ED to your friends and family, or any sort of variation of that, that this intervention can increase your score by 20% or more. But in addition to that, this is the kind of thing that has multiple other benefits, right? So you get to hear from your patients about their feedback in person talking to somebody. The nursing staff or whomever is performing these calls gets to help guide the patient in terms of questions that they had or that they thought of after their visit. Gets to make sure that their follow-up care is understood and is being done, right? And we've had many experiences where the number that was provided to the patient is just not in service, right? And so then that allows us to then go through the quality and safety approach of saying, why is this number still being generated on the discharge instructions if the ortho clinic has changed their number or whatever, that example. And then the other thing that can happen is that when we sort of engage with patients in this way, it gives them the sense that, it wasn't sort of just that we saw them as a patient and that episode was over, but that we actually have some continued sort of interest in their care and helping them. So we've had a lot of really great experiences with this. And if you can find the budget to do this kind of thing, it can be a really very positive patient experience intervention. If you can't, and now having done this lecture for a number of years, this is often the discussion, especially at AAEM. There is a very reasonable approach where you ask some provider that was involved in the patient's care to give a subset of their patients a call back, right? And having done this personally, it's actually a kind of nice interaction. And yes, you can do the whole selection bias thing and only call the nice patients and not so much the patients that you know are going to scream at you. But there is definitely an interaction that happens that is hard to describe from the humanism perspective. And so for any of you that haven't tried calling your patients back, maybe just try a couple just to see, because it really does sort of help with the engagement piece. I don't want to get too sappy about that, but I'll leave it there. So, in summary, environment of care improvements, thinking about providing food, providing comfort, improving the patient's perception of their care environment, reducing the delay to pain control, improving empathy and compassion, improving communication, trying to reduce weights whenever possible, finishing strong with good discharge teaching and education, and then finally a nursing or any callback program can be really effective interventions. Any questions?
I think all these are awesome, ideas to keep in mind, but how are you allocating resources? A lot of your depending on your cleaning staff and your nursing staff to make sure. So what success have you had to be able to nursing shortages and everything else, being able to accomplish these pretty straightforward, low-hanging fruit, but at the same time without the staff?
Yeah, so, that's a great question. So fortunately, we have a sort of a couple positive aspects of multidisciplinary work at MGH, and so there's been I think an interest in a lot of this from the perspective of the leadership level, right? And we've also had quite a lot of time, right? I mean, I was the clinical director for 8 years or so, and during that time there was just a sort of iterative approach to a lot of this. That's the other lecture that I give is on sort of PDSA cycles and iterative approaches. And so, for example, the nurse callback program was just something where our nursing leadership supported it, and it comes from their budget, right? So if you don't have somebody that's willing to do that, then that's, it's probably not started, and then we get to Brian's lecture on negotiation, right? But some of the other stuff is just, environmental services, if they're in a place where they actually want to have sort of an outcome that has some benefit to you, right? They're willing to do all kinds of different things, right? And that's where I think, sort of having a relationship with folks where, you can find that shared goal of not having the department look terrible. It may take some time, and that's where I think, to get to the nourishment piece, that's been a decade of conversations, right? It started out where our prior nursing director, the thought was patients shouldn't be spending that long in the emergency department if they get hungry, so we don't need to really provide them with food, right? And they can go to the cafeteria. And that conversation has taken a long time to sort of morph, but it's now morphed into the place where we have refrigerators that are stocked 24/7, right? So I want to be cognizant of the fact, though, that if you're kind of starting from scratch, I would maybe think about, again, that 2x2 of thinking about where your highest level of influence is and the lowest cost, and starting, in an iterative way. And for something like that, like staff training, just going to faculty meeting for 10 minutes and talking about Helen Reese's athletics model or something can be low hanging fruit. Is that a helpful answer?
Yes, thank you.
Other questions? Okay. Jamie and Brian.
We're getting towards the end. It's kind of the catch-all bucket here. So we are going to be talking to you guys about quality, a little bit about process improvement, mostly in the form of our clinical pathway discussion here. I'm Jamie Aranda. I'm a medical director at Freighter ED at the Medical College of Wisconsin. And Brian is going to be presenting the pathway section here shortly. So we have no conflicts of interest. So the Joint Commission describes quality as the degree to which healthcare services for individuals and populations increase the likelihood of a desired healthcare outcome and are consistent with current professional knowledge. So high quality care is timely, efficient, safe, effective, equitable, and person-centered. Historically, safety has been described as the avoidance of harm to patients from the care, treatment, and services that are intended to help them. However, we've focused a lot of our time and effort looking at the rare instances when things tend to go wrong, and more safety is being redefined as looking at the vast majority of the time where things are actually going right. So as we advance our understanding of what safety is, we are finding that we actually have a lot to learn from those times where physicians maybe intervene or make adjustments that protect our patients from harm. If you want to read more about this, there's quite a bit in the literature from Safety to 1 to Safety 2 by Eric Hallnagel, and it's a very interesting topic. So in order to lead effective teams capable of providing high quality of care, it's important that we make it clear what we're asking them, basically. So I know Dan talked a little bit about this earlier as far as like making clear what our measurements and expectations are, but it's important to ensure a clear vision, mission, values, and what our measurements and metrics are for our physicians. We ask a tremendous amount of our docs, in the form of high productivity, contributions to education, research, as well as clinical excellence. And, oftentimes I think we're balancing these in different proportions. And so what you're doing at your, community site might be a little bit different than what you're asking of your docs at the large academic medical center. We have some neighborhood hospitals that are very metric driven, and our docs get those newsletters every month that have all of their transparent metrics, door to doc times, patient experience, et cetera. Whereas at our main academic site, our docs have significantly more teaching responsibilities and some expectations from a scholarship standpoint. With regard to the role of the medical director as it relates to quality, it's important that we create a culture of accountability and develop our champions. I think just to follow up on that question about like how do we engage other services like EVS and nursing and radiology techs, et cetera. I get an email from our charge nurses like every 12 hours on a status update of our department, and we've done a lot of work to really kind of build out that positive feedback. So if we, see in the charge report that, Derek from EVS did a really great job going above and beyond cleaning the waiting room and doing a deep dive clean out there, our triage nurses will usually like include that in our charge report. And so I will reach out to his supervisor and I will say, thank you so much. That means a lot to us and we really appreciate it. So I sent out before this talk this morning, I looked at the 5 a.m. update. I sent out some emails and I think it's really kind of built out that positive relationship that we have with our docs, our nurses, and all of the ancillary service providers as well. With regards to coaching outliers and low performers, we did talk a little bit about like the transparent metrics earlier. Nobody wants to be like on the bottom end of that list. So usually people are very welcoming, at least my experience has been, to like, you know, what they can do to like help improve their performance, or at least like show that they're interested in improving. So that can be an important role as well. And then from an operations perspective, we just want to make it as easy as possible to do the right things. You know, we had a nice discussion during the break about some of the transfers from the main academic site. How do you get them to other hospitals? And we've been on this journey in our department for the last like year or two, and identifying barriers has been a huge project. How do we make this easier for people, for patients, for our nurses to explain what's going to happen next, et cetera? From a safety perspective, again, we want to create a culture that values safety. We really want people to feel comfortable bringing those concerns and complaints to us, and know that they're not going to be put, you know, like found at blame, that we're all in this together. We do frequently message out a lot of encouragement to submit safety events and in a non-punitive form, and try to take a systems-based approach so we can foster trust and really like demonstrate value by action. As a medical director, you may be required to participate in case reviews, root cause analysis, and harm prevention. I do want to pause here on the topic of root cause analysis, because it is kind of a logical fallacy that there's like one particular event or problem that led to a safety event, and I'll talk a little bit more about that in an upcoming slide, but nonetheless, a lot of hospitals still have that structure built out, and you'll have to participate in those discussions. One thing that we've done at our site is kind of reframe them as opposed to like a root cause, more like what were the major contributing factors, what were some of the minor contributing factors, so that we have some opportunity to move forward. I'm going to take the next 2 slides to just kind of use as like a case study what we did in our department. So when I started at Froedtert Hospital, we just had one large academic hospital for our staffed by our one group. And within like the last 5 or 6 years, we've added 2 high acuity community EDs. The VA has been added to our list of sites as well, and we have 4 neighborhood hospitals. And so we had quite a few challenges with this rapid expansion, particularly with like reporting challenges. So there were just very different processes at all the different sites, you know, patient safety events, grievances, things were coming in as like emails directly to our physicians and APPs. Oftentimes like unedited, verbatim, really hurtful stuff sometimes that was completely out of control for our docs. So we, and you know, like most departments are gonna have like these metric tracked events as well. We really did a lot of work with our hospital leadership and different teams to try and funnel all of that to our medical directors and PSQO first before reaching directly out to our docs. As far as like the outputs go, we have a lot of, from that branch point, we have a lot of different potential outputs. We do have some committees that do the work that comes out of these events, but essentially our joint quality review committee is a true like peer review committee. It's a multidisciplinary committee. It includes our operations folks, the medical directors, but we also have frontline faculty that voluntarily participate in that committee, and it's been very nice to have representation from our education faculty as well as the simulation team, because we were able to take a lot of the events and transform them into educational opportunities. And then we also have accountable care teams that can carry out some of the like process improvement work. If we have challenging cases or cases that resulted in like patient deaths, we'll often refer that to our peer support team. So we have a group of specially trained nurses, residents, and faculty that volunteer to undergo training and serve as the peer support for our department. And I think we were one of our first departments at our hospital to do this, and now it is present in multiple different departments. As far as like the education output, we do kind of harvest these cases for grand rounds, resident conference, etc. And we really do try to create a area of like safe discussion so that people are consistently exposed to safety cases and recognize that it's not meant to be punitive. We've seen a lot of benefits from this structured review process. We meet as medical directors from all of our different sites quarterly for a patient safety oversight committee, and we discuss trends and what some sites are doing well that's worked at their location that we can apply at other sites, and has really helped kind of cut down, I think, on some of the siloed and redundant quality improvement work that we do. And there's a limited amount of resources. Like, not everybody is going to be able to, you know, recreate the same thing at all the different sites. So we kind of like cross cover or help each other out with different things. As I mentioned before, some of those like unfiltered patient complaints that, you know, can sometimes be a little bit hurtful or inflammatory, we've been able to kind of like filter those out and send very like directed questions to our physicians so that they aren't seeing, you know, so-and-so's the worst doctor I've ever seen in my entire life and I will never go back to the CD again, kind of avoiding some of that language. And then this has actually worked really well in our academic environment. We have a 3-year emergency medicine residency right now, but I think we're all kind of eyeing some of the proposed ACGME changes. And there is, as you guys probably know, some quality improvement experiences required. So we do involve our residents in case reviews. Our 12 resident class each get assigned a single month of case reviews that they need to do. And they work closely with 2 of our medical directors and our PSQO to undergo training. And they will review those metric-driven cases, and they actually are empowered to escalate any cases that they come across that they would like reviewed at the Joint Quality Committee. So we've looked through like retrospectively, and they actually do a really good job. They identify all the same cases that our medical directors have escalated as well. So the chiefs run the quarterly meetings where they go over that. And then we, again, use that as a source for simulation, conference, et cetera. And then we've been able to like upscale this as we've expanded and added additional sites. I'm gonna just touch briefly on like the safety science and blame culture. So we work in, you know, very complex environments similar to like aviation, energy, et cetera. And so, you know, our systems are basically constantly bombarded with different types of hazards. And we're always putting in different like reactionary kind of policies or protocols or things that we can do to try and prevent harm. And unfortunately, hindsight bias can kind of impair that an understanding of what happens before the incident occurs, meaning we tend to oversimplify when we look back at a case. And so it's important, first of all, to be aware of the hindsight bias, but also to recognize that being aware, just knowing about hindsight bias doesn't actually like prevent it from occurring. And labeling something as an error does not explain why it made sense to the physician in the moment that the error occurred. I'll give an example. So we have had a handful of like kind of parallel cases that we've seen reviewed by the hospital as essentially they had kind of ruled it as like standard of care not met. In our department, we actually use most physicians would have acted similarly, some physicians would have acted similarly, or excuse me, some physicians would have acted differently, or most physicians would have acted differently. But essentially the case is a patient with renal insufficiency that gets a CT angiogram looking for, head and neck trauma, vascular injury. And we had a case where a physician did not order a test when it was indicated because of kidney injury, and the patient ended up having a vascular injury. And so the case was ruled as basically standard of care was not met. And then we had this almost exact same case where similar presentation, the study was ordered and the patient did not have a vascular injury, and that case was perceived as care not met, which, having this hindsight bias of knowing like what the outcome was of the CT scan really impacted that review process. The law of substitution is a tool that you can use. Basically, if you ask yourself the question, could this event occur with a different individual? If your answer is yes, then individual decision-making is not the causative factor. It may play a partial role, and we work in these very complex work systems that are dynamic and ever-changing. So we're always interfacing with our environment, the tools, technology, tasks, as well as the organizational culture. And so it's important to recognize that and just not oversimplify things. We are going to transition into a more detailed view of clinical pathways. I just wanted to touch on a couple of other tools that we don't have time to discuss here today. But decision support embedded in the electronic health record, I think it was alluded to earlier, some of the scoring tools and D-dimers, et cetera. We use a lot of communication tools, so we have like a templated doc handoff that we use for all of our admissions, and it includes code status, like what you're admitting them for, how many IVs they have, what their oxygen requirements are, et cetera, et cetera. And it takes about like probably 30 seconds to fill out. You just like click through it. But it's been a huge satisfier for our docs as well as the inpatient teams, and has really been perceived to improve our communication. SBAR is another tool that we use for a lot of our like operational updates in our newsletters, emails. EMS now uses it as well. So we've kind of standardized that communication tool. It stands for Situation, Background, Assessment, and Recommendation. It's kind of like the SOAP note of messaging. And then standardized discharge instructions and smart says can also be very helpful, especially like meeting some of those like regulatory requirements, like including post-sedation instructions, et cetera. So I will pause there and plan on transitioning to clinical pathways unless there's any questions. Okay.
Thank you, Jamie. We will jump over into talking about clinical pathways. So I think that we'll use, and I'm probably want to move quickly again. We can handle that. All right. So I want to talk about clinical pathways because they're a really important bridge between operational aspects of the emergency department and your quality and safety divisions, which should be working pretty closely together. Functionally, the definition here is these are kind of structured multidisciplinary care plans used to establish the steps in a process in your department. Functionally, they're fancy checklists. They are steps that you have to do. These are used in all sorts of other industries. They're used in aviation, to like talk about how to fly a plane, what to do if a certain situation comes up, and how to navigate that. These are things that you want to be employing because they can provide standardized recommendations to kind of minimize variation, and they can help link the current evidence and with how your care gets delivered for certain conditions. And so we'll talk a little bit more about these as we kind of move through this. This is going to be a condensed talk on a very broad, very broad topic. I just want to highlight that there's a lot of different types of pathways. You can make a pathway for almost anything. A lot of them are operational in nature, and what's our agreement with consultants? Who gets consulted for kidney stones versus who doesn't need to be consulted at all? These are ways that you can minimize that variability with what you are doing to kind of reduce the amount of work and ensure that the same standard is applied. There's also clinical pathways, which are a big thing that I'm sure many people in this room have been involved in, which is how do you define the treatment regimen to ensure that things get ordered correctly every single time for certain problems. This is trauma, trauma, stroke, STEMI, DKA. We have a lot of different pathways, but we've done a lot of these at our department looking at pancreatitis, CHF, other things in that nature. And you can also apply the clinical pathways to undifferentiated problems like syncope, something that can have a really variable workup. You can have kind of a checklist, a document to make sure that all of your residents or attendings kind of go through a checklist each time to say that, so that we can avoid, do the appropriate workup, not overdoing it for certain things or not underdoing it. So some of the motivations just about pathways, just to take a step back, are a lot of these came from lean processes that happen at different institutions, looking at ways to get things done faster, to get patients seen, moved faster, scanned faster, or from like big ACOs to reduce the total medical expense. A lot of these stemmed from looking at avoidable admissions, patients that came in and then were only admitted for 24, 36, 48 hours, and then were ultimately sent home to look at critically, did these patients need to be seen in the first place? And there was a lot of talk about the benefits of that, of the hospitalist happier to not have to do all that paperwork and potentially send patients, focus on the sicker patients. Patients are usually happier, to get care at home outside of the hospital if it can be done in a safe and effective way. And us as ED physicians are probably more happy to not have to play the middleman between those conversations all the time if we have standardized approaches that we can follow. And so a lot of the benefits rise from reducing cost, improving safety, and standardizing care. The key question every time that you as an operational leader in your department are looking to develop a pathway is what question or problem you're trying to solve that standardization will help with. Is there some wide variability in treatments or diagnostics that you would want to employ so that things are being done in a similar manner? Obviously there's some leeway, but things that will be done kind of smoothly and efficiently. And we get the ideas for these cases from a lot of different areas, and I'm sure everyone has plenty of examples and we can talk about them, but talk about them in the panel. But a lot of these are short stay admissions. We got approached by low risk CHF patients, so that we end up doing a lot of ED observation at our institution. Can we give a few doses of diuretic, get close cardiology follow up, actually get a documented weight, and get them established for follow up? And would that save save the hospital some time? Money.
How does that benefit the ED? Now you're diverting the task onto the ED, right? You're saying, okay, well now instead of getting it on the inpatient side, let's go to the ED. Let's take it out of the bed so a patient is in the waiting room. I don't know if that's necessarily necessarily making efficient care.
Yeah, I think that's a great point, and there's a lot of nuance to that. I think it depends. Pathways can bridge a lot of different things, but for ones that you're looking to employ ED observation, yes, you have to look at what's the impact on your departmental workflow, nursing workload. Do you have the space to hold this patient for another 6, 8, 12, 24 hours? Some places don't. What is the downstream effect of that? If these patients get admitted, are you then holding a bed, and are you now holding another patient as a boarder in the environment we're in, because that patient is living where the hospitalist isn't going to round for another 12 hours and discharge them later? Is there a safer cohort of patients to free up the inpatient beds? Yes, and in a vacuum, you're providing some extra level of work for that for the department in the moment, but in kind of the greater scheme of what you're doing to establish the appropriate patients that need to be admitted, there's a little bit of a discussion that you'll have to partnering with some of the hospitalists. But I agree, it does add work. We have a dedicated observation shift, which is a whole other conversation about that. But other ideas for these come from those admissions I talked about. A lot of QA cases that come up are flags. We developed a strong pathway we had a an instance of cases with, cauda equina suspect patients that were getting delayed MRIs. So we developed an operational pathway of who meets the threshold for an emergent MRI, how do we do it, what's our communication threshold with MRI to get these done quickly and more efficiently. Faculty interests are also really important because you're going to need a champion for any one of these pathways. So our toxicologists really wanted to refine our alcohol withdrawal pathway, or our buprenorphine initiation pathway. So you're looking for people in various aspects of your department to focus on this. And then the key with any of these, as was mentioned by Jamie, is you're really going to need to talk and involve all of the stakeholders in this. So if you have an idea for a pathway, who is affected by this, anyone that's touching the patient really needs to be involved, which is your physicians, your nurses, your technicians, phlebotomy, radiology, all the consultants, potentially outpatient providers. There's a ton of different things that you're going to need to be involved. I want to take a minute or two here just to talk about how potentially leveraging the electronic health record for decision support, and this is going to vary by institution, but I think a lot of issues that people have run into with these pathways in the past is you have the pathway and people don't necessarily use them. They don't know to use them, how to access them, and if you can, depending on your electronic health record, put that information in front of your clinician, that's usually kind of the better way to do it. And if you can leverage the EHR, we had an old homegrown EHR that did a wonderful job of this, where it would pull actually potentially their PCP group who had certain pathways who like to send a lot of patients home with cellulitis, or it would pull chief complaints or medications given and say, hey, based on the lipase, would you consider the pancreatitis pathway? We just moved to Epic within the last year, and it's been a little challenging to do that. So I'm interested if other people have been able to integrate these, but leveraging that, because you're not then relying on each individual person every single time to remember that this pathway exists. One of the key things in terms of monitoring the utilization of your pathways is actually tracking who is enrolled in these, if you can. So making a dummy order, making ways to include this in your electronic health record so you can track this down the road. So you can say, is our prompts recommending patients, and if they are enrolled, then we can track to see what's going on with them. And if they're declined, are they declined appropriately? And is there a reason? Did they have an exclusion or an exclusion criteria? So we can use this data on the back end as we're kind of rehashing and refining some of our pathways. Jamie brought these up, but they kind of are enrolled or kind of layered into the pathways are the order sets, which are really important in terms of when you're defining and sitting down with your team to outline the steps in your pathway creation. What tests do you want to order? What medications do you want to give? What are the thresholds, and how do you standardize this? And having these and building these out in conjunction with your information technology team is really important, because these do provide standardized care. It also helps you hit your metrics so that you're not forgetting to reorder a lactate or forgetting to order the appropriate fluid boluses for sepsis. And on a similar vein, having these integrated with your discharge planning so that every time you're not having this, a rotating resident remember to put the same criteria, you can have, as best you can have it kind of pull dedicated discharge criteria that we've done, recommend common medications, help set up referrals to follow-up visits. So those are really important to integrate. Just because we're limited on time, we'll talk through a little bit in the steps and pathways, but one of the key aspects of pathways is really being very specific about your inclusion criteria, your exclusion criteria, what are the steps in the workup, and then at the end of it, what are the ultimate, what is the next step in the patient in terms of where are they going next? And establishing very clear criteria on when you're working through these of who needs to be admitted, who can potentially go home, and what criteria do they need to hit. And this is a good opportunity as you're building these pathways to sit down and kind of map out what do their lab values need to be, what do their vital signs need to be, what does their follow-up need to be, and so you can kind of get very granular with a lot of these details. The evidence for clinical pathways, they've done some, there's been Cochrane reviews on looking at these from the inpatient setting that show that they reduce, basically can reduce in-hospital complications and improve documentation without affecting your length of stay. Looking at some of our own pathways, we've seen a reduction in admission rates with, while monitoring the 72-hour bounce back rate. You can look at length of stay for those patients, which, as you mentioned, does go up for some of the observation criteria. But if you're looking at you're seeing if you can reduce your admission rate. So they are usually an effective way of standardizing these processes. I'll run through these quickly, but I want to talk about the steps in pathway creation because I think this is kind of the nitty gritty. And if we had more time, this is a good opportunity. Sometimes we've done this in workshop form and other venues to talk through having people practice with a group working through how you establish a pathway. So the first things you want to identify are your inclusion criteria. You want to be granular and specific. Who is being involved? What ages? What chief complaints? How are you identifying these patients? Is it based on lab values? Is it based on anything you can pull from the data? Is it based on their past medical history? And just as important as your exclusion criteria, if you're establishing a PE pathway or a DVT pathway, maybe patients that are already on blood thinners, or maybe patients that are already have active cancer, you don't want to include those because they may not fit the model that you're trying to do. You want to think a lot about the immediate side effects of your pathway as you're building them, which can be the effects on the department as a whole. What is the nurse load going to look like for your physicians and your nurses? So nurses going to be having to do regular neuro checks. If you're doing a TIA pathway, or are you going to have to? Do you have the space to care for this? We did a lot of pathways with some of our community sites where we've avoided transferring kind of low risk, traumatic brain injuries based on a teleconsult instead. But one of the side effects was that our community hospitalists don't want these patients anywhere near their sites without neurosurgeons. So what steps do we have to build in to make them feel comfortable with this, or what exclusions do we have to put into the pathway? You also need a very good plan to analyze and regularly revisit your data. You need to make sure that the pathway is applying to the patients that's actually getting used for the patients you intended. If you run your numbers and you find that you have an average of 100 syncope patients a month and you're really only getting 20, why are you missing these? Are they excluded appropriately? Is there an opportunity for these pathways to have more, to be uptaken more? I mentioned champions briefly. These are really important. You have to have somebody that's dedicated to the pathway, that's looking to advocate for it, to do education on it, and to analyze this data and to adjust it as new evidence comes in. And you really have to have buy-in from your department, your QA leader, usually some general pathway position as someone who can oversee all of these. Having really strong people that are advocating for this is helpful. And then training is the last aspect. Once you have designed and developed a pathway, you need to make sure that this information gets out to your staff. Especially as academic sites with rotating residents, you need this information to be accessible. You need it to ideally be asynchronous because we all miss faculty meeting or miss resident didactics or whatever your unifying meeting is, just because our schedules are so can be variable, and you need to make sure that there's a way to track that everyone that knows what to do. So just in the interest of time, I'll move through this, but these last few slides here are just kind of your pathway to creating a pathway, which is where you decide, have an idea of what you want to do, you frame the problem, and you figure out what the goal of it is. Is it to decrease testing? Or is it to decrease your CTAs and order those D-dimers? Or is it to reduce admissions or to improve, kind of adherence to a certain metric? And then you need to figure out all of the stakeholders and get them together, find a meeting, figure out exactly everyone that touches the patient, and figure out the amount of people that this is going to involve. If it's going to be 20 patients a day and that's going to be a huge lift, that may be difficult it may be too burdensome depending on your department. And then you have to sit down, and the meat here is to develop the pathway, which is looking at the evidence, what's best practices, figuring out who you want to include, who you want to exclude, and then what the steps are that, someone that comes in with a TIA, what qualifies them to be high or low risk, what tests are involved all the time, and then what are the results based on those, including your appropriate discharge criteria, your admission criteria, and then ensuring that your consultants are, obviously aligned with this so that they can continue that care inpatient or in the outpatient setting. As you're working through this, we're looking at all of the administrative logistics that I just touched on. Do you have the ability to do MRIs rapidly? Like when we were doing that pathway, we had to work very closely to, who is getting bumped for an MRI and how are we getting that patient there quickly based on the suspicion. If everyone that comes in with back pain is entered into this pathway, that's going to clog up, every aspect of our department. So working on the logistics of that with our radiology colleagues, figuring out, who is tracking this and how we're getting this data, and then, basically how we're going to look at everything and analyze it afterwards. So once you've rolled it out, you determine the go-live date, you figure out what metrics you're tracking, and you make sure that your education is in line. So that was, in the interest of time, I kind of ran through that quickly, and we can happily take questions now or at the end of the panel. Yes?
pathways have been great at our ED and reducing admissions.
Yep.
The problem we run into is we want more spots in clinics, and they just can't give us more. So have you run into that, and do you have any tips that are universal across institutions that might be helpful?
Yes, I think that is obviously a huge thing, is getting appropriate outpatient follow-up, and those, stakeholders, and I don't know if you have specific examples. Is it just general medicine, or is it?
So the two that work for us is we have an AFib pathway and
Yep.
a neuro pathway.
Yep.
But we only get about 10 slots a week in
Yeah.
clinics, and our volume just seems to be going up
Yeah.
for eligible patients. And we just, I wish they had 30 slots.
Yeah, I think gets back into some of the negotiation things of pulling your data, seeing going into those conversations with those people who are very clearly stakeholders in this pathway, and I'm sure love not to have these patients admitted, because you're reducing the burden on them. They no longer now need to see these as an inpatient. They're freeing up a bed for some other procedure, and going in and saying, hey, we have this many. We could fill more slots if you could provide a safe discharge for them, because that's obviously. It would be awesome if we as the emergency department could just generate those spots, but we are forcing them to kind of adjust their clinic schedule. And if they could we have neuro-urgent care follow-up for some of these, and we have a lot of spots with them because they know that reduces the amount of patients that they need to see, round on, and kind of clog up their inpatient service. So I would say going in with good data, with metrics that show the kind of the progression over time is the most helpful thing, because that's a resource that you are not able to provide yourself, and you require some tact. Oh, yep.
Do you find ever, as you roll out more and more pathways, that there's a groups of physicians that push back or say they don't want to be told how to practice? And how do you approach that conversation?
Yeah, there's early and late adopters of everything. I think you want to. I wouldn't say there's people that just refuse to do a lot of the things. I think it depends on how extreme you are with your pathways. If it's something that's a very clear deviation of care, most pathways have some language and allowability for physician gestalt. If I feel like something is off, then you have the ability to deviate from those pathways if it's clinically reasonable. There's some times where certain order sets, or we're trying to hit metrics, but in terms of treatment algorithms, if I feel this AFib patient really needs to be admitted, there should be an outlet valve in a lot of those pathways. And I think the key is tracking those. Who is enrolled in the pathway, and looking at are these patients appropriately admitted? Are they deviated, and why do they deviate from the pathway? So you can kind of look and say, do we need to kind of make things more stringent or more relaxed? Or if it's a single individual person, kind of going up to them and saying, and seeing if there is a specific issue, if it's a pattern. So it can be tough. I think there's a lot of allowability of a range, but obviously I haven't personally run into people that are just like, screw this pathway, I'm just ignoring it. I'm ordering CTAs on every patient that says the word chest pain. So I haven't had that.
So this past year, one of our department managers was not.
Yeah.
Yeah, we had something similar at one of the institutions I was at. When breaking the pathways, it would be like unequal. Like you recognize that a pathway can't fit nicely into a patient, but as long as you do that, document the reason for it, because if it's an adverse event, you better be able to explain that if you deviated from the pathway. Is how we framed it in a nice way. But and then say from an education standpoint, I think they were concerned, where they were like, well, how will residents learn how to manage these patients without pathways, and really using them as teaching tools is how we reframe that conversation too. But yeah, we always got some resistance.
Yeah. And there's a whole discussion there about standardizing certain aspects of care and the balance at academic sites and education. If you have standard triage order sets and every patient comes back with troponins already ordered, how are these residents going to know if they need to order a troponin? And that's where you're drawing on your faculty's expertise, while you're kind of doing this it's the balance of patient care and throughput and flow with some level of education without taking away that autonomy.
I think the data too, there's this been actually a few times, but if you show that it's actually solving that problem that you were aiming to fix, or showing the impact of the pathway, I think we'll get smart.
Thanks, everybody. I'll pass it on to
All right, so now we're gonna briefly talk about you. So, as all of you that work in operations realize, the danger when you do operations is that there's always another fire to put out. So if you don't take some time to concentrate about you, yourself, and your career, the actual day-to-day work will just consume every waking moment available to you. And then, 5 years later, you're gonna be sitting there going like, what just happened, right? So I just want to talk briefly about, what you have to do. I also have no conflicts to disclose. I'm sad about that, but, someday.
If you're able to do it in 20 minutes or less,
I can certainly do that. So preparation for a career in operations, do you need a fellowship? I would say nowadays you probably do because there's a lot of fellowships out there. So if you're looking for a career in operations, that's probably going to be the price of entry at a lot of places now. That was probably not true, 15 years ago, but nowadays I think it's much more true. Do you need an advanced degree? So I think if you ask people that have advanced degrees, they'll tell you absolutely you do. If you ask people that don't have advanced degrees, they'll say, why would you bother with that? The truth is, because a lot of fellowships offer an advanced degree as part of the fellowship, it's becoming much more common that you're going to have an advanced degree attached to it. So we get back to the same thing. At some point, like the price of entry is going to become, if you don't have an advanced degree, it's going to be much harder to find a position. So, like I said, fellowships are becoming, standard. There are a bunch of certificate programs out there that you may want to also consider. I think, either the ASIP or the AAM ED Directors Academies are in general a good overview of like a lot of the stuff that you're going to have to worry if you're going to have a career in operations. I don't endorse one of them particular or the other, but it's something to think about as part of your fellowship to get sent to one of these programs. Again, there's plenty of advanced degrees, they're extra letters. You just got to figure out which one, matches your needs, your interests, and, cost is also a consideration for some of these. So, like I said, you need any of these. It's becoming, I think, more common, so it will become necessary at some point. Then the thing that you have to think about that nobody can give you the answer because it really depends on what you want out of life. It is, what is your goal, both in emergency medicine, in academics, and then what are your other life goals and how does that fit into the rest of your life, right? Some of these things may be kind of mutually exclusive, so you have to like sit down and kind of figure out what is it that you want as opposed to having somebody tell you this is what you should do. And then I think you should always have contingency plans because, no plan lasts first contact in battle, so having other outs will be important for you to kind of be able to pivot. One of the big things, there's SAEM, so, we all think that academics is very important, but, you got to sit down and really kind of think about is, how important is it to my life, to my career? Is this what I want to do? Because there is a significant amount of like time and effort invested if you want to do academics. And if it's not, a big part of what you actually are looking for downstream, then, that time and effort may be better spent doing something else to advance your career. If you work in an academic medical center, depending on like where you work at, research may be a small or a large proportion of what, is expected of you. At a lot of academic centers, if you're like an operations person, they're like, it's just, as long as you keep the trains running on time, like, we're not going to make a lot of demands on you in that respect. But realize that for your next job, it may be important to, have some academic productivity. So that has to be something that you have to like kind of get into your workflow so it doesn't suffer. For a lot of academic centers, research is a big part of academic promotion. And if you don't have this kind of baked into your work schedule, it will be very hard to succeed in that area. So again, what are your priorities? Do you have a career plan? If the answer is no, then you should sit down and kind of figure out what you want out of life and, what your 5-year plan, 10-year plan is and how to achieve it. And make sure that that plan takes into account the rest of your life, right? Right. If you have a plan that doesn't kind of take into account, your spouse, your children, your other responsibilities, then that plan is probably going to fail, right? So be kind of realistic about what else you have to commit, time and effort to, so you have something that like makes sense and doesn't generate, unrealistic expectations. And like I said before, you should have multiple contingency plans for, you know, when things kind of take a turn that you did not expect. So you all know these Venn diagrams. So this is how I kind of put life in perspective in my mind, right? These are the three things that like matter at work, you know. These are the things that you're good at, the things that you like to do, and then the things people will pay you for. All right? If you are in a job where you have a lot of overlap on these three things, you are doing great, and then you will have actually a lot of opportunities, right? If you have no overlap, you should find a different job. And then at the end of the day, these circles are not like static in size, right? You can become better at more things, and you may find like new things that are interesting. And then those two things should be the driver of like trying to figure out, you know, how do you negotiate with, you know, your chair about, you know, these are things that I'm good at, I'm interested in, and then figuring a way of how to get paid for them, right? Because if you don't get paid for them, then, you know, it just becomes difficult to have a job, because at the end of the day, the goal of a job is to generate income for the rest of your life, right? So thinking about your career path longer term, you know, the other thing to think about is like there's a lot of things that like a career in operations should prepare you for at the hospital level, and being able to think about these things strategically and longer term will be useful, because to get into some of these positions will take time and like long-term planning, right? You're not going to become a CMO like tomorrow just because you felt like it, right? There's going to be a lot of steps that you're going to have to put in place to be able to get like to the place where you can like get a CMO position. But there's a lot of intermediary things that are available, I think, at the hospital level outside of the emergency department that may give you a lot of visibility at the hospital level and will make you much more attractive candidate for some of these hospital level positions. Time management, like I said before, operations will consume every waking moment of your life. So if you're not proactive about like separating time for long-term goals, you're kind of guaranteeing like that you will have no long-term goals that you'll accomplish. What I do is and you may not be able to do this, you know, to this level, but it's something to think about. Like Fridays, for example, I designate as my no meetings day. So I will not allow other people to schedule meetings for me on Fridays. That's the time that I get to like actually work on my long-term goals and actually schedule a lot of meetings for like things that like may not be like immediately operations dependent, but may have a lot of value for like my career or something else, right? So if I have like meetings with people that I'm like doing research or like trying to plan things for like the longer term, that's when I kind of arrange it for that time. But you need to find some chunk of time that is dedicated to you and your longer range plans, because if you don't, like nobody's gonna make that time for you. As much as you can, right, in operations, you're gonna have so many meetings that you need to kind of have a much more regular schedule than like the standard EM schedule, because if not, you know, you're gonna be asked to work, you know, an 8-hour shift and then like have a bunch of meetings either before or after. And that's just a guarantee for you just being like completely burnt out at the end of the day or the week. And then you have to account for the rest of your life into your schedule, right? I say operations where academic careers go to die, because it's true, because you have so much work to do that you don't have the time to do like all the other things that you need for academics unless you're proactive and kind of conscientious about it. So again, if academics is a big part of your life, you have to figure out what does it take for you to get promoted at your institution, and then kind of work on like doing the things that are necessary for that. Okay, so the other thing to do is also kind of double or triple dip into things, right? If you have an interest in like, you know, patient experience, you know, you should be able to lecture on it, write about it, right? And then you take, you know, a paper that you did and you talk about that paper, you come to SAEM and talk about it, right? So you do 1 unit of work and you leverage that 1 unit of work into like 5 different things that you've done that now go on your CV, right? Which means that you like have leveraged that into like academic promotion, right? You do all you do operations, so you should be good at being efficient about some of these things. And then you have to figure out what's valued at your institution, so you can kind of leverage the things that you do in a way that maximizes that value and effort. In terms of research, you also have to figure out, you know, what's your goal? If you want to just do the bare minimum not to get fired versus, do you want to do NIH funded research? Those are very, very different goals and will require very different strategies. But, publications, and then what I tell people is like operations is like perfect for publications, right? All you're doing in operations, if you're using data correctly, is you're doing a bunch of before and after studies. So you should be able to write about it. The issue is most of us don't have time to write about it because, again, the moment you solve a problem, you just uncovered 5 more that now you have to like deal with. But there's where you have to like leverage some of the things that are around you, like the people that you work with, to try to like get everybody, some value. And then you should start small. There's like one of the earlier projects that I did, and the goal for when you look at this, and you should be able to go like, he managed to publish that, and the answer is yes, I did, and so you should be able to do the same thing, right? Start small, and then you should be able to build into like bigger, more complicated things. But if you've done an operational project and you have data behind it, that's a study. You just have to figure a way to publish it so you can get more value out of it. You had a question?
Yeah, like how do you have at your institution, is there a way, or is it streamlined if you're doing operations research and not going through the whole IRB rigmarole? So I feel like that is a barrier for me and like a lot of other people in operations.
So most IRBs have what's called an exemption for like QA work.
Yeah.
And we liberally exploit that loophole because most of the stuff that we have is not like PHI, right? It's not like patient, like directly like related. So like we're doing all this stuff for QA, and then we use that like carve out as a way to get like a lot of research published.
And your IR, like your institution's IRB office, like has a process where there'll be like QA exempt.
Right. Most institutions should. It's like a
QA, like multiple committees with the department, so it's like.
It's not even that, it's an exemption based on some like chart like data. It's not like perspective.
But there's a way to massage it. Most of what we do in operations should be able to kind of like, with different levels of enthusiastic pounding, fit into that box. And then don't be afraid of rejection. Honestly, just because you got a paper rejected once doesn't mean that the paper is crap, and it doesn't mean that it won't get published. Honestly, the way I approach things, if I don't get rejected on the first try on the paper, then I feel like I left some money on the table, and I should have tried for like a higher impact journal. So my goal is to get rejected on the first go around, get some useful kind of feedback, and then if the paper is not fatally flawed, then submit it somewhere else. And as you do that, you build a network of collaborators. And then these collaborators will kind of change jobs and institutions and go somewhere else. And now you have like the opportunity of doing kind of multi-center research because people at various places. And it's not fast, but again, if you have a plan and a long range goal, then you can kind of do some of these things and like slowly it will start bearing fruit. And again, leverage the research you've done into, presentations because it's also valuable for your CV and, it gives you external visibility as we're doing right now. So if you build a few talks that you can give multiple times, then, you get better at the talk, you sound smarter about it. And then you can kind of like go and give the same talk at different places. So just talking about my experience, I didn't come into operations initially. I started working at some project in Italy, developing emergency medicine there. Which, as you can imagine, it was horrible living in Italy for several years. But then I got bamboozled into doing operations by somebody, and then that's how I started into operations. And then so I tried to kind of like leverage what I was already doing into like building research, and then as time went on, I've used different people for collaborators, and that's kind of slowly how I built like the research side of my career. I was never interested in becoming like an NIH funded researcher. I had clear, understanding of what my limits were, but within those limits, I feel like I've been able to kind of like work with a number of people and like be able to like grow a lot of the emergency medicine operations research. And then kind of maintain output, right? You should always have like another project that's like in development stages. So as soon as you get something published, you already know, what the next 5 things we have to work on are, right? And I kept it short. There you go.
We're gonna transition to a panel discussion. If folks need like a minute or two to run to the bathroom or things like that, go for it, and we'll get set up to do that.
I don't think we can actually fit everybody behind this exciting panel-looking chair, but maybe we can just kind of do a little semicircle or something.
We're gonna advance one slide.
Okay.
Should we all just stay where we are?
Yeah, I mean, well, maybe have like a couple seats over here, and we'll have the 3 back here. I think it's a little bit better when there's like a row as opposed to everybody kind of clustered in one spot.
Yes. We'll take it.
Thanks.
Oh, gosh. I did not think about that.
Yeah.
I think you might be in the like too.
Yeah. Sure, we'll just shift everything.
Yeah, I like that.
That'll be fun.
Are you okay that way?
That was fine.
Yeah, I wasn't sure, but I'm like, I'm short enough where people can still like see the other people like. Benefits of being short.
I know, I do.
Well, they're gonna be people behind too. Oh, I think so.
Maybe we can just move everybody in front. That's fine. Sure.
And then, yeah.
Hey, because Josh is moderating.
Yeah. Oh,
Perfect. Oh, there. I thought the negotiations went really well. I was trying to do my part. Everybody not sure around.
Are you,
We already clarified.
But there's a faster way to do it, or there's a better way to do it.
A better way to think about it.
We're moving the table because I have to talk about student theory.
Mm-hmm.
You got your math wrong?
What?
You got your math wrong?
His math was correct. It just needed a little presentation boost,
Yeah. Empty hour in front of the EV and 24 people.
Yeah, there you go.
And like,
Exemption options for Ireland, because they're supposed to have things.
You go to 30.
Yeah, 30, yeah.
That like to, if it doesn't work, that exemption.
All right, Josh, we'll get started.
I think we do. Do we have everybody? All right, given that we're a little bit low on time, and I think we do want to definitely take some time to get this panel together. These are the panel's disclosures in entirety. I don't think anybody has a meaningful conflict of interest about anything we're going to discuss today. Here is our panel. A lot of people have spoken. We have a couple of people we're adding. I'm just going to kind of go down the line here. We have Dr. Bella from Mount Sinai. We have Jamie, who gave a talk earlier. I'm Josh Joseph. I chair the Administration Operations Committee for SAEM over at Brigham. Tareem spoke before. Leon just spoke. We got Brian, Wendy, Dan Shaw, Ben White, and Brian. I'm going to just kick things off. So we had a question earlier about staffing models and what kind of are the staffing models that work in an academic setting. I'm going to just kind of offer up, has anybody in the panel had a really good or really bad experience with a particular staffing model for academic faculty, and why? I'm going to call on Lan.
Yeah, I mean, I'm not really thinking about this by staff. Well, at the end of the day, right, you have to figure out. In my mind, the way we built staffing models, like, you know, there was a range when staff locations were out of attendance, right? Like at the end, right? You can't expect any attendance to like process 6 pages now, regardless of how many like residents and PAs they have, right? Just legitimately, if you're seeing 6 pages now, man, like the amount of content having to application is so small that it's just not anything they're gonna be able to do. And then there's a bottom, right? It'd be great, you know, we'd all be very happy if we only saw 1 page an hour, but then we could be getting paid like $50,000 a year, right? So there's some economic kind of like floor that I think sets the level of like what people need to see so they can get paid, because at the end of the day, right, that's how you generate money, right? So mostly by the clinical. And then there's a ceiling of how many patients people can see, and that is much more kind of, I think, local dependent, because it depends on a lot of the infrastructure, all the other kind of resources that you have, and also like depends on kind of the level of like interest in it, like certain implications, and honestly you're paying on like a BI, for example, you know, the model is that you get paid essentially by legit income that you generate. So people are much more willing to kind of have like a much higher patient than per hour than anything like the web algorithm, where you get paid a straight salary, right? If you know you see 4 patients an hour on shift, and you get paid exactly the same amount of money that if you saw 2 patients an hour per shift, you want to see closer to 2 patients an hour before, right? If your income goes up by how many patients you see, then you know you're gonna be much more willing to see more patients, but then you have to like cap it, because then people get greedy and they're like, oh yeah, doctors want to see 5 patients on a shift, but then you get to the point where like that may not be safe to do, so then your pressure is just this knee-jerk will be essentially. So I'm not sure that answers the question, but those are the things that are important, and you know how to like sort of schedule.
Can I just follow that with more comment?
Yeah, go for it.
Because I love the idea of using data to model out your arrival rates and the amount of work in using demand capacity matching. But I think one of the 2 concepts that are relevant is one which is called pooling servers. And so the idea that if you have somebody, especially a very expensive resource, who's underutilized and their service capacity is by definition perishable. Like if you're sitting there at a computer and you don't have a new patient to see, right, you're wasting that person's time. That being a little bit flexible with allowing your most expensive resources to be pooled and see multiple different types of patients, for example, could be really effective at home.
No, it's not doing
Okay,
anything.
great. Can everyone hear me? So pooling servers is something that is, I think, especially in our split floor departments, not a common concept, right? Like you don't get up and leave your area to go help your other, you know, sort of clinician colleague necessarily, unless you're encouraged to do so. But to Leon's point, if one of the questions is, are we going to waste our resources and be paid less, then that's an argument to be made that maybe, you know, sort of staffing in that way can be helpful. Then the second concept is being okay with, especially physician scheduling, not fitting the 7 to 11, 7 to 3, 11 to 7 sort of nursing approach, and allowing your overlap clinician staff to come in at crazy hours, right? And we've had shifts that go till 2 a.m. We now have one that goes till 3 a.m., which is bonkers. But like having that sort of demand capacity matching, I think can allow for a narrative in which you're saying we're trying to meet the volume of patients that are coming in a way that's most effective for all of you to have a better shift or day.
Sir, could I just add some context to my question?
Go for it.
The question
Yeah.
was between, if you're an academic site, you buy some community chefs who have a fully academic staff, who now some of them say, like, why am I working in the, it takes away from my research, my house, my teaching, and this, versus having a hybrid. I'm just curious if you guys have experiences with that, what are the pros and cons, happiness of your faculty. So the advantage of the hybrid model is that it allows you to increase the size of your academic faculty, right? So if your academic faculty only works at your academic site, right, there's a limit to how many number of staff you can have based on the number of shifts available at your academic site. Now, if everybody works like 30% of the shifts somewhere else, now you have the opportunity to increase the size of the academic faculty, which as chair, it would give you like the opportunity to recruit like more specific targeted number of individuals, etc. It also allows for people to become institutionalized, right? So it forces the academic attending to be functional outside of an academic medical center, which is important from them being able to teach emergency medicine to residents. And number two, if you have a system, it allows people to see what the other side experiences, right? Because another problem when you become institutionalized at academic medical centers, like, well, we just like talk about the outside hospital is transferring the patient, right? And outside hospital always is every problem, right? Always should have gotten this other consult, and when most of the time, these people are transferring patients to academic medical center because those resources are not available and their pressures are very different. So it gives these people a lot more empathy and understanding of like what the wider system is, and the truth is most academic medical centers to survive now are going to have to become systems, right?
Well, just to add on that, I agree with much what was said there. I think there's an additional thing, Chairman, if you have multiple sites, and for faculty, it improves career longevity, wellness. It just makes, all of us, the more we do one thing every time, that one thing, it wears you down. And so even if both states are challenging in their own way, they're different. And so I think I've seen this effect where it improves people's life outlook, perspectives, wellness, like how enough of this place, I over this place, I get fresh food. So there's that advantage you need to. So I'm a relatively new chair, so with that caveat in mind, I'm personally a big fan of people having multiple practice sets in some fashion. I'm not overly romantic about it. Not everyone needs one. For example, we're never going to have a thing in our shop, and it's not a singing aspect to the setting. Where I was previously at Penn, there was a much stronger emphasis on two-site practice, but even then, it wasn't a rule that everyone had to. But it was encouraged, and I think that's a nice sort of vibe to put in encourage multi-site practice. When it works for people's lives, the geography, and some other things, within reason, because there's a lot of advantages to recruiting. One of the ways we're using that assignment currently, to your point, that is very important to have more faculty on the graph, is it's a long story. We've set up a 24/7 urgent care system, and we're sort of siphoning off some time and completing academic faculty staff that we pull out for more lives, more faculty at the main practice site in the stage. So that's sort of a strategy to have a larger faculty, as opposed to if everyone was just full time, full hours at the station.
Only two quick comments, and some of them that came from a hybrid system that works in one. I do think from a sick call and sick pool, it can actually cross coverage and cross credentialing is helpful. If someone calls out, you can shift. There's the ability from looking at if someone calls out of my community site, can I pull somebody if they're not credentialed? That can be helpful. And the second aspect, and we haven't talked about, we touched on with resident education, but knowing how to operate outside an academic site is, I found when I talked to the residents, a big draw. Knowing that like their attending has put a chest tube in the last 6 months and knows how to do it, instead of just being working in an academic. Like I haven't intubated at the big medical center in a very long time because there's layers of residents. But when I'm at my community side, I work on nights in the community. I'm the one there. I get to do all my procedures, and I feel like my skills are better. So I feel like the residents just anecdotally seem to appreciate that.
I think also you can start sending some of your learners to the other sites when you have people that are comfortable and like teaching working at those sites. So we just added a required emergency medicine rotation for our medical students, and now we send them to all our sites, and our faculty love it because they feel like they're all alone at the
solo site, and now they have some students and stuff, so it's been good.
I think there's also a large number of people who are kind of in the wings of academic medicine who don't want to be kind of hardcore academics. And if you have an affiliation with one of these sites, you're also growing the number of people and also a lot of the residency graduates you may have who are interested in teaching, but don't actually want to pursue a career as a residency director, as a kind of core researcher, somebody who maybe does not want to be held to, yeah, I've really got to publish or perish, but who still wants that toehold. I think there are a lot of excellent clinicians that I think pass through that maybe they don't always have a totally realistic idea of what it means to be in academic medicine, who I think are really well suited to that role, to being the community attending who still has a toe in the waters at the academic medical center. I think it's also just can be very helpful in terms of recruiting people who maybe are still feeling out where they want to go or if they really want to have a fully academic career. And if they're still primarily based at a community site, that allows them very much to flex in, flex up, flex out as needed.
Thank you guys for this great talk. A lot of you have mentioned data and how important data is. Like I feel like operations and data are often tied together, and I feel like a lot of us used to have to getting data out. I think it's really hard, overburden and list. So I just kind of want to know from best practices you guys have maybe developed at your different sites on like how working with that team to make sure that you can get data that's necessary to like show success of your work. Because I feel like that's often the bottleneck. It's just getting your data and timing the action that they can actually use. So there's this interested that you can multiple those numbers.
Yeah, one thing that has been particularly helpful for us is that when we create dashboards, we kind of also anticipate what additional data we need. So one of actually the most helpful dashboards we have is just like a very granular data of every patient that comes in. So when we pull that data, we're able to like break it down into exactly what we need without actually having to go to our analyst. So that's been really helpful.
So I am a great consumer of data. I'm not great at extracting data, but you have other people that are good at it. And that's one thing I would say, right? As you go on your like kind of operations career and start like having influence over being able to hire people, you should find people that are better than you at something, right? That way you can kind of leverage like everybody's different things that they're good at. So like kind of construct a whole that's like much better than like one individual. And then you gotta go to like your institution and say like data is king, right? If not, it's just garbage. You have no idea what you're doing, whether it's effective or not, right? In the environmental, like money is tight. If they can't provide you with that, then you're in a lot of trouble. But then you gotta cheat, right? I have Josh for like a lot of the things that we've done, and he took the full kind of epic course and how like plug into the matrix and like be able to extract stuff. I will never be able to do that, right? But at least I have somebody that knows how to do it and can kind of tell me, okay, well these are the things that are possible, these are the things that we should ask for. But if your institution is unwilling to kind of provide you that basic piece of data, then you have to ask them back, okay, then what is it that you want me to do for you? Because if you want to be kind of conscientious about the cost of things and doing things that are effective, the absence of data is just meaningless.
I also think you don't always have to use really sophisticated data too. Like I am terrible with computers. I also ask a lot of other people to give me information, but like even just like the number of patients seen on this day when you get an extra APP or like you can pull a lot of that stuff just from like Slicer Dicer too, which I again am terrible at, but I have used it to like leverage hiring, asking for additional FTE or things like that. A nocturnist position, so really basic stuff that if I could do it, but you can.
And it's like a structured database too, in some ways with Epic, like depending on what institution you're at and what privileges you have. Like where I'm currently, I don't have like the privilege anymore about like directly accessing query portal, but I think that one of the benefits, and I'm curious what Josh thinks, but like I think with like AI, right, like ChatGPT can even help you like kind of come up with some of the querying. I'm sure it isn't perfect with SQL, but you can kind of at least like tell you like the basic language they can kind of pull in and play around with. So it's, because you're literally like looking for column A, row B. I mean, it's not, you know, it's that structured data that you can sometimes pull out.
So it takes a lot of those words, SQL, clarity, snowflake, gibberish, which was, and it was very, very true for me, which is why I think Josh really should give some, his answer to me. One of the things I found helpful is having a person, that overburdened analyst, right? Help you to create a recapitulatable system through Epic. Because Epic has people that have generated these reports for other departments. And so if you sit down and have a meeting and say, these are the data that I want, and it needs to be free and unencumbered from other people getting involved, because I want to be able to do this on a Friday night, maybe not Friday night, but some, 5 a.m., right? I wake up and allowing that sort of interaction to happen can get you to a place where you can access the dashboard and understand it. And they built it because it helps them, that you're not sending them your like one-time data requests for reporting, numbers over the last month, so you can compare them to some other metric, right? And having also now recently tried to get into some of the deeper layers of Epic to use AI to look at patient experience data, I have to tell you that is often the feeling there with me being involved, right? So I'm going to hand it off to Josh because I feel like he probably has had a lot of experience with these types of discussions.
Sure, I'll grab that question next. Having spent the last 12 years on the data end of things, there's a lot you can do, but also a lot that will be asked of you if you happen to develop a facility with things. I would say that the hardest thing, and if anybody has unlocked the secret, I don't know it, so I'll ask you, is trying to get people who are in a position controlling purse strings to understand that there is a lot of work that goes into not only getting data, but often maintaining the data that you have. One of the biggest issues is that somebody will write a report, and then that report will get used kind of year after year, and the folks who commission the report see it as a done deal. Again, if you think about a house, if you buy a house, there is the cost that you sink into buying that house, but actually what you're buying is time on all of the pieces of the house that will eventually corrode and break. And there are two ways to approach that. You can either do regular maintenance, which costs money and is painful because it seems like you're not really getting anything for the money, or you can try and fix things after they're broken. And fixing things after they're broken often can be a lot more painful than just that little bit of regular maintenance. And it's unfortunately, I think, with a lot of the stakeholders we deal with, it is really hard to get folks to understand that it really makes sense to pay for that regular maintenance. And what ends up happening is that instead, you have a report and then somebody either wants it to function when there's been a major change in the ED. I don't know, maybe you added 20 beds, or maybe you added a new observation flag that wasn't there originally, and now you have patients whose length of stay now seems to be 100 hours. That has totally made your average length of stay data nonsensical. So it's hard, and either you can get lucky and you can find an analyst who really knows their stuff and can kind of hear the clinical side of things, because that's also a huge issue. Is that usually the hospital analysts, they see their little data buckets and they have no sense of what this actually means clinically. I'm talking too much, but I'll share a really quick example. So at an institution I may or may not have worked at, there may or may not have been a report that was used to determine physician bonuses and compensation. One of those items was chart completion. It's an important thing. I mean, again, I think we all have our experiences about who lets charts sit for a little bit too long. But there was an issue in that the analyst running the code, and this was a report that had been generated 5 years before that he was basically just hitting run on, quarterly, found that actually about half of the faculty were delinquent in terms of their charts, beyond whatever the departmental guideline was. And so with that, you lost about 50% of your bonus for that quarter, which is substantial. And again, there is issues with repeat offenders and so forth, but we suddenly went from having like maybe about 10% of the faculty kind of not meeting this to close to 50%. And, well, the analyst basically said, hey, the numbers are the numbers. This is what the report says. That's it. I was asked politely to see if I could investigate this a bit more. And as it turned out, in terms of the actual report, they actually couldn't find for almost a third of the charts a number for what the amount of time to complete the chart was, because they just couldn't link it. Things happened, patients got put in OBS, and so like the OBS chart was never linked. There were all kinds of inconsistencies. And it was kind of like, okay, well, to the analyst, what are you ruling an inconsistency as? Oh, well, I'm ruling an inconsistency as a chart that was never filed. So every single chart that could not get matched was just listed as a chart that was never done. So suddenly you had people who like get every single chart done within 24 hours. Their data is now in, 50% of their charts are done, day of service, and then 50% of their charts are never done. So, it's like, hey, you can't simply say every chart that I can't find is therefore a late chart. So we got rid of that, and lo and behold, the numbers were consistent with the way they had been for every other quarter previously. But there were suddenly maybe a lot of faculty members who were owed a lot more money than they were otherwise. So, to me, that's a personally very consequential kind of thing. But if you're simply relying on somebody who has no attachment to the data, you can get some really bad results.
Okay, just had a quick question. I wonder if any of the panelists, so my background is trained on academic center at Penn, actually, before you got there, was finished residency, worked as clinical staff, more staff in one of our residency training programs, the military program in San Antonio. And now, for the past 17 years, been in the community where at a very high volume, high community facility that has residents, but our staffing is around where we don't have residents, assuming we're not gonna have residents, so we staff for attendance to see everybody. We've been tasked with starting the residency program in the next 2 to 3 years. So my question is there anybody who has had a foot in academics as well as a community ED? And what are the challenges and differences of both, and what are some of the things kind of what to expect?
We're all looking at you.
Yeah.
No. So I do a lot of my practice in the community, as do a number of the folks who are on the panel. I think the question is how consistent is it going to be? If you're going to have residents on shifts all the time, then I think you can start to build workflows around them. So we're like trying to start an elective for residents at one of our sites, and I'm just assuming that they're not going to do anything differently or anything additive at all, as far as seeing patients. And I think if as they're more integrated, as you're building shifts around them, if you can count on the resident in your schedule, maybe they then start to substitute for PA shifts if you have those, or maybe they then start to use the needle on things. But I think, and I'm curious what other people think about this, the question is consistency, and then how comfortable are they with that site? So if you're building a residency program, then obviously you're going to have that schedule that's going to set up to optimize for that. You can start to rely on residents to see some number of patients. And then some of this is staffing model too. I mean, one of the academic site that I work is essentially resident driven, and so the idea is that attendings will essentially not primary patients, as opposed to a model where it's kind of a split. You're saying residents going to see maybe 2 patients an hour, and at their very best at the end of training, probably more like 1 to 1.5 an hour, and then the attending going to pick up the slack, and maybe there's some benefit as they move through their training. I mean, I'm curious for folks who've done this longer than me. My sense is that interns are going to take more effort. Second years and third years are going to be about even a lot of the time, potentially helpful as far as the volume. And then as you get toward the end of training, you're able to get some multiplier out of that as well. I'm curious how other folks think of that.
Yeah, we kind of substituted in our residents, they were started at our community site as second years. So we did substitute in for APP shifts. But I would also just add that depending on like the growth curve of your site, it might make sense to just leave your staffing and add them in, because if that first year they're not that helpful, maybe by the time your third year, then they're actually like, you know, helping a little bit, then maybe your volumes are gonna be such that you need more help anyways, which is what we did. So after we substituted in our AP for APP shifts, then after like 2 years, we had to add that APP shift back in anyways, because we were, you know, seeing a 10% increase in our volume anyways, so might not plan for any decrease.
And my comments are not for any residents or fellows in the crowd. They're not meant to be derogatory at all towards residents, obviously. I went through residency, everybody goes through residency, everybody training. I think there are just the realities of how we have the staff to support that and to achieve that mission.
Yeah, I mean, I think it's a complicated question. I'm happy to talk to you afterwards and just kind of get a little bit more clarity about what it is that your ED's experience and be able to give you a more appropriate answer and address it again. Depending on like what the suggested answer would be. I think.
And the productivity numbers are now different because it's supervisory, right? You're not asking them to attend someone to see 2 patients an hour. Primarily, you're asking them to supervise, 2 residents seeing, a total of 3 patients an hour, and are you also asking them to then see primary patients, or are they only supervisory shifts and you have other attendings working? So it gets a little more complicated when you're kind of figuring out where you need bodies.
Just add a few layers to that is that I think so we've at my institution we've looked at our residency productivity, and it's almost like buyer beware. As an intern, it almost will take more work and potentially could affect your own like attending productivity. And so like again, don't assume PGY4, PGY1 will have the same productivity. I think the second layer is if you have pre-attending shifts, and so then if you have a PGY3 or a PGY4 program, and they're now managing the interns, like that's going to affect your attending productivity in a sense, and like potentially help it and maintain it, but just keeping in mind how you set up those shift structures are going to, at the end of the day, affect patients per hour. And then the last thing is, we have this vertical area, and specifically, that's volume, like, and we put our PGY4s in there because closest to graduation, they're going to probably spend a lot of time managing efficiency and throughput. And so we were pretty mindful saying, like, we're going to put PGY4s in that vertical area, which is a throughput engine where we're expecting 2 patients per hour. We're not going to put an intern because that's really going to then affect their productivity.
This may be a dumb question to talk to an academic panel, but do any of you have faculty who do not work with residents and their primary goal while on shift is to move the meet? Because that's the model we're looking at. Is we have faculty, we're a community ED community program, and we have faculty who don't want to work for residents, which is that's where we are right now.
There are places that have models like that where they have what they call like teaching shifts versus like non-teaching shifts. Like they have a portion of the shifts like non-resident attached and then we just working and everything. So I say like it all depends on how much the size of your ED is.
Another fairly standard model is to do it by areas of the disease, so it's about that. So for example, we have areas where the mostly are, and areas where they're coming in. And that allows you for a little bit of flexibility because faculty could, if you're allows it, work mostly or exclusively one area or another. So that way, it's not that faculty self-identified. There may be some inelegant aspects to that, but faculty being identified, so I don't know that you resident identified. There's okay, create some cultural issues. But if it's just by shifts, so it's a little bit more subtle, it's like, okay, I don't want to work with this one. I'm like 90% just gonna do shifts in this area where you see people, as opposed to shifts where they're the teaching areas. It's you want to get the same facts, but in a little bit more of a subtle method.
You might also take advantage of the like sorting aspect of that. So like we do have one unit in our department where there's not a resident, and that unit or that attending doesn't take resuscitations, so they are just, you know, seeing patients that are like, mostly like ESI 3s, but, you could, if you were gonna break it up into like a different geographic space, you could consider the possibility like the higher acuity, better teaching patients, maybe go to this side, and then the lower acuity, we just gotta turn these people over and get them going, and then we go to the other unit.
We got time for one last question.
This is a little bit related, but I'm just thinking, currently hybrid site, community hybrid system, or where you have multiple patient strains, you're gonna have a spectrum of productivity among the providers. So I'm curious what Ann thinks about the tension between equitable shift distribution, and productivity. You know, certain docs are gonna see a lot more people that can afford or fast track with residents without like, how do you balance that? I think productivity has to be, so this is something that we did, at Brigham, productivity has to be shift dependent, right? Because even if, say, everything else is equal, everybody has the same number of residents and all that, the proportion of shifts that you work at different times of day have an impact on what productivity is, right? The overnight shift will see a certain number of patients versus 7 to 4 versus 3 to 11. And if your shift distribution is different in those 3 versus somebody else, you may have a very different productivity output that has 0% to do with you yourself as a person, right? So the correct thing to do is you have to normalize with those shift distributions to be able to compare apples to apples, right? Because if I'm working all 3 to 11s and Ben is working all 7 to 4s, I'm gonna see more patients than he does, but it has nothing to do with me. It has to do with the fact that I'm working different shift complement. So to normalize that thing, you have to kind of account for those shifts to be able to, and if you're going to like have that be part of your compensation package, right?
Or you just say the benefit of working the 7 to 4 shift is, well, you might not get as much of that like incentive pay, you know, because we don't normalize a lot of our stuff, but as I say, there are definitely attendees that work, like people that have a lot of admin duties will tend to work more daytime shifts, so the nocturnes are seeing more of the like low acuity and higher volume, and then, but sometimes we just say it's a wash, like, you know, we do that for our APPs, if they work in the fast track area, they're gonna see a lot more patients per hour, so their patients per hour incentive pay is higher, but they don't like those shifts as much, they see a lot of people, and they don't have an attending over there, and so they get a little bit more bonus if they work more of those shifts, just because it impacts their entrance. It's kind of a wash, and they just understand that, and they still trade shifts, you know, like some people prefer to work on a different team, so.
Yeah, like it depends on your incentive structure too, like depending on what shop you're at, like some shops will do like RVU per hour, and so if, for example, you have a split flow model, and you have like a physician in triage. Some people enjoy them, some people don't. We still do them, because you're turning to me. But then that will impact your RVUs per hour, so then that will help you, depending on whatever the incentive structure is. You realize that may not be your favorite shift, but it's a shift where you will generate a lot of revenue for the department.
I think another major part of this is not only how are you going to kind of conceive of what the equity is going to be or equality among your providers, but also how essential is it for people to take certain shifts? If you have a couple of dedicated shifts where maybe people are not teaching and they're just moving the meat, if those shifts are the anchor of what keeps your department afloat, you might want to really incentivize people who are willing to work a lot of those shifts. Avoid editorializing that further. I want to thank everybody for the time, for some great questions, and people will be around to chat afterwards.